For those of you who have not met them, Judy Satana for our Public Information Unit, Donna Wortman, our Assistant Director of Operations, and Paul Murphy, our Director of Operations. So, thank you.
Thank you.
So I'm going to start with some basic information, and that is, what is a state agency for purposes of benefits? There is a lot of confusion out there for especially our offline agencies. They don't understand that they are a state agency as far as we're concerned, not a municipality. So state agencies, pretty intuitive, include the executive department employees and retirees, the legislature, constitutional offices, and the trial courts, and state higher education employees and retirees. So all of these agencies are considered online because there's an interface between our MAGIC system and their payroll system. So these are considered HRCMS and UMass payroll systems. And when you look at your procedures, you'd want to look at the online or HRCMS and UMass procedures. Now, our offline agencies include assorted governmental entities, planning councils, counties, and there are 256 housing and redevelopment and other quasi authorities. These are all considered offline agencies for state benefit purposes. So you also get the state employee benefit decision guide, because your employees are eligible for basic and optional life insurance, long-term disability, health insurance, pre-tax flexible spending accounts, the buyout program, and then only the executive office's the dental vision program. And then your retirees are entitled to basic and optional life insurance, health insurance, retiree dental, retiree vision discount plan, and the health insurance buyout. So Chapter 32B came into effect back in 2007. It was later amended, and it allows municipalities to join the GIC for health insurance benefits only. There was legislation that now permits municipalities to offer our retiree dental plan, and they can opt in twice a year. So when you go to our website, I wanted to be sure that you're all familiar with the coordinator section of our website. So the very first section here is locate your GIC benefit coordinator, and here is a list of all of you, your agency division number, your phone numbers, and so your employees can locate who their coordinator is. Coordinator news, the procedural memos that are in your packets are under the annual enrollment news. The coordinator training, we're going to post the video here, but the dates and locations are there. Health New England is hosting a breakfast meeting, and that information is here. And then over time, I send out emails to various folks. For example, municipalities have received some requests from CMS on data, and that information I always post to the coordinator section, the coordinator news section, so it's always there for your reference. Ordering supplies, here again, all of the contact information for our plans, whether it be the health plans or long-term disability, life insurance, all of their contact information is here. So if you need provider directories, if you want brochures, this gives you the information for contacting. Our regulations are posted on the coordinator section of our website, so I'm going to go over some changes that have to do with our regulations, but that is also here for your reference. And then, as I mentioned, our step-by-step procedures for you are listed here depending on which type of agency you're from, HRCMS and UMass, municipality, or offline agencies. And then the EAP program that you'll be hearing more about later on today, that information is also there. If you go to our homepage, the most most used section of our benefit decision guides are on our website in text format. So again, there's the 3 versions. There's the active state employee, there's the retiree, and then there's the municipal one, and that is all located there. The most used section of our website are the FAQs, and I strongly encourage you to become familiar with this section of our website. This provides information on dependents 19 to 26, layoffs, divorces, FSA, turning 65, probably the most frequently used asked question at our health fairs, long-term disability, and qualifying status changes, and the grid that's in your packet today. So again, a great resource for you, and definitely want to use that. In the event that you have a coordinator change, you need somebody to be added, deleted, address change, phone number, email change, send an email to our operations department at the email listed. Please include your agency division number. We have, because of the different benefits, depending on who you are, there are different email lists. So if you're from the trial courts, you're on one list, higher education another, municipalities, and our operations department also needs to make changes in the MAGIC system. So it's very helpful for them if you include the agency division number in those requests. So the commission voted regulation changes March 2nd. They're in the process of being promulgated through the Secretary of State, and I'm going to go over some of the changes that may affect you depending on what kind of agency you're in. If you're an offline agency, you're now going to be held to the same standard as the municipalities as far as notification of terminations. So in the event that you have a terminated employee, you must report it to us, because otherwise you can be assessed a penalty. And what this has to do with is the monthly reconciliation process. Please be sure when you get those, that reconciliation, the monthly reports, that you review them, you make sure that the people we say you're covering, that there hasn't been a change in those reports. It's very critical, and this is what the penalty will be for failure to notify us. Municipalities, the regulation changes make clear that teachers are eligible for health insurance during the summer months. Their deductions need to be made. Last year, the budget made changes to the deadline to notify us of withdrawal. It was moved from October 1st to December 1st, so that's reflected in the new regulations. And then if you do not withdraw by that deadline, you're automatically renewed for the minimum period. The PEC agreement that we have from you will stay in effect until we receive a new PEC agreement on premium splits. As you know, last year, because of the fact that health insurance is a pre-tax benefit, we needed to tighten up the qualifying status change rules so that we can continue offering health insurance on a pre-tax basis. That's something we definitely want to preserve. Having health insurance on a pre-tax basis is a terrific benefit, and so we need to abide by a lot of rules and regulations to make sure that we can continue to have those benefits. Let's say you have your annual premium for health coverage is $5,000 and you're in the 28% tax bracket. That represents a $1,400 savings to you because it's a pre-tax benefit. So that's just one example of why it's important that we follow all the rules for pre-tax benefits. So the regulation changes include all of the qualifying events, the fact that there's the 60-day limit on qualifying status changes, and that because of the Affordable Care Act, of course that wasn't contemplated when our regulations were last done, that we are now required by the Affordable Care Act to collect Social Security numbers for every insured we cover. So all the dependents and spouses that we cover, we have to have Social Security numbers because, as you know, for this year, under the Affordable Care Act, it was required that folks receive in the mail that they had health insurance I imagine in the future it'll be similar to the math side where you actually have to list that information on your tax form. We don't know yet how that'll work out, but we imagine that's what's going to happen. So as a result, we conducted 3 mailings this last fall to collect Social Security numbers for the people for whom we did not have Social Security numbers. And this makes clear that we have to have those Social Security numbers. The regulation changes also include the fact that our decisions are binding and that we determine the effective date and decisions. Leaves of absence, same thing as far as the 60-day notice. Terminations, when an employee terminates coverage, their coverage goes through the end of the following month. And ineligibility, if insured or his or her former spouse remarries, coverage ends on the date of remarriage. So this also makes that clear. We've had a couple of very tough cases that have to do with this, but we can go back and collect any claims that were paid on those ineligible people's behalf, and or the premium that was due to us on a full cost basis. So this is really critical. You've got to notify us of any remarriages, and we tell the employee and the retiree that in multiple ways throughout the year. Our benefit statements include this, our newsletter, our benefit decision guide, our website, and we also depend on you to make sure your employees know about those rules. Does anybody have questions about the regulation changes? Okay, so I'll go on to what's going on in the healthcare market. As we all know from the news, healthcare costs continue to skyrocket at unsustainable rates. Healthcare costs are squeezing the rest of the economy. And I will take you through briefly what are some of the factors of why healthcare costs are going up so rapidly. So our first, we start the rate renewal process back in the fall, and the initial rate requests from our plans were at 7.1%. We did a lot of negotiation, and the final weighted average increase is 3.6%. Some of the plans did better than this, and some did worse than that. It's more important than ever for employees to look at their options during annual enrollment. We have a lot of very similar plans. Benefits are almost the same across all of our 11 or 12 plans, depending on how you count, with or without CIC. And you can get the same benefits with lower costs with different carriers. So this shows what's happened to the state budget just in the last few years, with healthcare costs skyrocketing and other areas of the state budget getting squeezed. Healthcare costs include the GIC, but on a bigger percentage basis, it's Medicaid and the connector. So why are healthcare costs going up? There's a couple of factors. One is that we pay substantially different rates depending on the hospital and their market clout. So if a mother gives birth to a child, uncomplicated, just a normal delivery, healthy baby, average cost at Mass General is $18,500, whereas if the mother delivers at St. Vincent's, it's $12,200. Big difference in cost, same exact outcome. More of us are getting our care at the expense of hospitals. So just in 2009, 58.3% of Massachusetts residents got their care at the expense of hospitals. That's gone up to 60.6%. And meanwhile, care at the lower priced hospitals has gone down. This is not only driving up healthcare costs, but it's hurting the economy because a lot of these community hospitals are the big employers in those communities. So as we continue to move to the expensive hospitals, a lot of those community hospitals will go out of business, and that has an adverse effect on the economy. Then prescription drug costs. I've had included a lot of articles about rising drug costs in our newsletter. They are out of control at this point. We have fabulous drugs out there with specialty drugs. They do amazing things, but they are extremely expensive. So Harvoni, a couple of hepatitis C drugs, depending on which drug you pick, both Gilead Pharmacy, it's $84,000 or $94,500 per patient. You multiply that by the number of people with Hep C, we're talking serious money. Additionally, specialty drugs are being developed for people that have a very common condition like high cholesterol. I bet a lot of people in this room have high cholesterol. New specialty drugs that treat high cholesterol, $14,000 per year. So just huge costs, and we've got to pay for it. And then Big Pharma is doing a lot of consolidation and driving up the price of long-time drugs. So both brand name drugs and generic drugs have seen rapid increase in price over the last couple of years as they have consolidated. You've probably all seen, Michael Skakel taken off to jail for tax fraud, but not for jacking up the price of drugs. And he took a generic drug that was $13.50 a pill, and it's now $700 per pill. Been in the market for 10 years. So annual enrollment is April 6th to May 4th. As I mentioned before, it's more important than ever to evaluate your options. There is no longer a deductible barrier for switching plans because the calendar year deductible is now a fiscal year deductible. Whether you stay in the same plan, you switch carriers, you stay with the same carrier, you're going to have a new deductible on July 1st. So the in-network deductible is unchanged. It's $300, $600, $900. And then if you are in one of our plans with out-of-network benefits, that out-of-network deductible, which is a separate charge, is going up for July 1st. So this chart is in your packet, and it's really more of a comparison between within the same carriers. I like to include it because it gives some context. So for example, if I was in Fallon Health Select Care, they're reporting there's 24,000 physicians in Massachusetts in their network, whereas there's 9,500 in the direct care. It just shows from within carriers the difference in network size. You'll see, I would not compare that versus Harvard because they must be counting differently. I don't think there's wildly different provider counts between the various plans, but within the carrier, it's pretty accurate to point out, for example, Navigator versus Spirit, 34,000 versus 16,000 in Mass. You'll see here is the list of hospitals, the total count of hospitals. So there's 73 hospitals in Massachusetts. You'll see that almost half of our plans include either all or most of the hospitals in Massachusetts. And then over here, there's a comparative list of the price. So Unicare Basic continues to be our most expensive plan, but now Harvard Independence has jumped to the #2 most expensive plan. And that plan's cost is substantially more than plans that are identical to it, namely Tufts Navigator and Unicare Plus. So this is the full cost municipal rate sheet. This shows the same information, but from an actual dollar standpoint. So this is the amount that is paid by both the municipality and the insured. So for family coverage, with CIC, you'll see that Unicare Basic is $23.46, and then if you go up to Independence, it's $19.99. So very close. Very similar premiums, and yet Unicare Basic is every doctor, every hospital in the world. So Harvard Independence Plan is closed to new members. What that means is that if you are already in the Independence Plan, you can stay there if you so choose. They do have a 9% increase for July 1st. Very expensive plan. If you're in the plan and you want to add your spouse, add a dependent, you can do that. But new groups, new employees, and folks that want to switch plans cannot go into this plan. The Harvard Medicare Enhanced program and the Primary Choice plan are still available, and you can enroll in those two plans. So I like to start with this page of our benefit decision guide because it helps you start to narrow the options. So you can see if you live in Hampden County, select Independence, Primary Choice, Health New England, Neighborhood Health Plan, Navigator, Spirit, Basic, Community Choice, and Plus are all fully available in this area. Direct is only partially available. So it helps you to start narrowing down your options. And then you can go to the rate sheet. This is the state employee rate sheet. You'll see that if I switch from Select Care to Direct Care and I had family coverage, I'd save $102.18 a month. If I went from Navigator to Spirit, I'd save $108.16. If I went from Independence to Primary Choice, $125.23. And then I'm noting that Health New England, Neighborhood Health Plan, Community Choice, and Plus have very attractive premiums. So we really want to encourage people to consider a less expensive plan, either a limited network plan or a wide network that has the same benefits but has a lower premium. The grid that's in your packet is on our website, and that website address is in the benefit decision guide.
Take action during the Group Insurance Commission's 2016 to 2017 Fiscal Plan Year Annual Enrollment. Consider enrolling in a less expensive health plan. The health plan calendar year deductible is transitioning to a fiscal year, so there's no longer a deductible barrier for changing carriers. This video covers the steps you should take to weigh and evaluate your options. You will also learn about ways to lower your out-of-pocket healthcare costs throughout the year. Annual enrollment for benefits effective July 1st, 2016 runs from Wednesday, April 6th through Wednesday, May 4th. During this time, you have the opportunity to review your options and make your benefit selections. Take the time to consider your healthcare needs and those of your family members for the upcoming year. Evaluate your options and determine which GIC health plan is best for you. Review the benefit and rate changes that go into effect on July 1st, 2016. Be sure to do your homework even if you think you want to stay in the same plan. Review and weigh your options during annual enrollment. Refer to your GIC Benefit Decision Guide, which contains valuable updates and plan information. Start with the rates to see what you will pay for your monthly health plan premium starting July 1st, 2016. Consider enrolling in a less expensive plan. Second, go to the Health Plan Locator map page to see which health plans are available in your area. Third, read the health plan description pages to compare the features that are important to you. Does the plan offer care coordination by your primary care provider? And are there out-of-network benefits? Consider enrolling in a limited network plan to save money on your monthly premium. Limited network plans have the same benefits as the wider network plans, but have a smaller network of doctors, hospitals, and other providers. Look for the limited network icon in your GIC Benefit Decision Guide for more information. If you don't want to change to a limited network plan, consider a different wide network option. Most wide network plans have similar benefits and networks of doctors, hospitals, and other providers, but can have different monthly premium costs. Be sure to find out if your and your family members' doctors and hospitals are in the plan's network. You can visit the plan's website or call the health plan's customer service line to find doctors and hospitals in the network. You must specify the plan's full name, such as Tufts Health Plan Spirit, not just Tufts Health Plan. Contact each health plan you are considering to find out about other features that are important to you, such as prescription drug programs, wellness discounts, and mental health coverage. If you are a state employee, Review your benefit decision guide to understand other GIC benefit options being offered, including pre-tax flexible spending accounts. If you need help in making your benefit decisions, be sure to take advantage of the resources available to you. Visit the plan's website to obtain benefit details, information about network physicians, and tools to make healthcare decisions. Call the health plan's customer service line. Plan representatives can answer questions and help you find providers. And attend a GIC health fair during April where you can talk with plan representatives and get personalized information and answers to your questions. Be sure to refer to your GIC benefit decision guide or the GIC's website for contact information and health fair dates. Keep in mind that enrollment forms are due to your GIC coordinator no later than Wednesday, May 4th. If you decide to keep your current health plan, you do not need to complete any paperwork. Your coverage will continue automatically. Visit mass.gov/GIC/forms to access enrollment forms. Note that all GIC forms have changed for coverage effective July 1st, 2016, so be sure you use the new forms. It is important to understand that your health plan selection is binding. This means that once you choose a health plan, you cannot change plans until the next annual enrollment period, unless you move out of the plan's service area. Once you are enrolled in a health plan, there are many ways you can limit your out-of-pocket costs throughout the plan year. Work with your primary care provider, PCP, to navigate the healthcare system and coordinate your care. Seek care from Tier 1 and Tier 2 specialists. You pay the lowest copay for the highest performing doctors. Tier 1 specialists have excellent quality and cost efficiency scores. Tier 2 have good scores, and Tier 3 have standard scores. If you are in a health plan which tiers hospitals based on quality and/or cost efficiency and have a planned hospital admission, talk with your doctor about whether a Tier 1 hospital would make sense for you. Bring your plan's prescription drug formulary with you to doctor visits so you can discuss which tier your prescriptions fall under and see if there are lower cost alternatives available. Drug formularies can be downloaded from your plan's website. Consider using urgent care facilities and retail minute clinics instead of the emergency room for urgent, non-emergency care. Use your health plan's online cost comparison tool to shop for healthcare services in advance. Some GIC plans even give you a check when you use this tool and select a lower-priced provider. And remember, the best way to try to reduce your healthcare costs is to adopt healthy lifestyle habits. Take care of yourself by eating healthy, exercising regularly, quitting smoking if you smoke, and finding ways to manage stress. For more tips on managing your health, visit mass.gov/GIC/yourhealth, where you can read articles and find links to additional resources. To get started on the next step for annual enrollment, read your GIC Benefit Decision Guide and visit the GIC's website at mass.gov/GIC. Thank you for actively evaluating your options and taking charge of your health.
So I will be sending out an email that includes that video at the end of this week. And I'll send that email out when everything is ready on our website. We're still working on the final things. You may or may not know, but the commission did not elect to freeze Harvard until March 2nd. That affected pretty much every page in the benefit decision guides, and I am one person. And we have 300 pages on our website. All of our forms were redone. At a glance brochures, rate sheets, everything for the fairs. So it's been a major sprint this month, and I will send the email out. Don't forget, annual enrollment doesn't start until next Wednesday. I will take you through the forms. They have all changed for July 1st. They are on our website, but they are not yet ADA accessible, which is required. they will be by Friday. So I'm going to invite the health plans up here to talk a little bit about some of their programs, and they will each introduce themselves. Eric, are you starting again?
I'm happy to, unless Glenda wants to.
Sure.
You want to? Okay. All right. Yes, you had a question? Changing your health plan as far as individual to family, family to individual.
Oh, okay, so it said something about birth and adoption?
Right, that you can change the coverage, not the health plan. Okay, and I'll be talking about qualifying status changes a little in after the panel session. Oh, where's he? Are you want to stand here? Sure. Great.
I'm Glenda DeBarge from Health New England, and we are one of the limited network options with the GIC, as mentioned earlier. For the actives, it's the HMO active plan that's available, and then for the retirees, it's the Med Plus. We are an HMO plan that's, our service area includes the 5 counties, primarily in the Golden West of Mass. It's Hampden County, Hampshire, Berkshire, Franklin, and then all of Worcester. As far as hospital network changes, we've not had any recently. I think the most recent one was Harrington Hospital as of last year, and that's located in the Worcester area. But we do have 20 hospitals, as stated earlier in the chart, throughout our network. Okay. The handbook distributions, for the actives, we will be sending out a postcard letting them know that you could go to the GIC launch page on healthnewengland.com and access your member handbook there. We're required to send actual member handbook paper copies to the retirees, and both of which will be sent out by June 22nd. Pharmacy programs, I just want to mention our PBM, our pharmacy benefit manager, is Catamaran. It has merged with Optum, so you might see both names. If you have those old Catamaran forms, it still applies, but it now is become part of Optum. Some of the programs that we have in place include step therapy, where a member may have 2 medications to treat a condition, but they have to try drug B first, and if it doesn't work, then we would approve drug A. So that's our step therapy program. We also have prior authorization, which mainly is for tier 3 medications, those more expensive brand medications that have a generic available. And prior authorization is where your physician needs to submit the paperwork, have Health New England review the criteria for that medication, and will be reviewed and approved. And then we also have quantity limits for some of the medications where maybe it's an X number of pills for 2 milligrams or 4 milligrams for that medication. Formulary changes, we have a clinical review team that meets throughout the year to discuss new medications that are coming onto the market, what tier they'll fall under, the criteria again for the folks, the members for the medications. And then we also notify our members through our semi-annual notice of change, which we send out twice a year. Okay. So a program that we've implemented or added to Health New England for members to help reduce cost is Teladoc. I think most of you are already familiar with it. We actually added it last August of 2015, and it provides members access to U.S. board certified physicians. So if you don't have an urgent care available to you at 8 o'clock at night, or your primary care physician's office is closed, you could call Teladoc or have them give you a call. It's available through FaceTime or telephone or video. You could say, I've got sinus problems, talk with a physician. They can even write you a script for your local pharmacy. And the consultation fee is $20, so it's tied to your primary care physician copay. A program that we've also helped or are available to our members to help reduce their out-of-pocket cost is our cost of care estimator, or cost of care calculator. It's through the member portal on our website, healthnewengland.com. And if you enter in a procedure like a back surgery or knee replacement, and also enter in your zip code, it gives you a low, mid, and high range for our providers in our network, and gives you the amount that it would cost. As you know, you've got copays and deductibles first for same-day surgeries or inpatient hospitalizations. This will give you an idea of the cost within our network. And again, it's a low, mid, and high range for our providers. Okay. If there aren't any questions, thank you very much for those who've RSVP'd to my breakfast next Tuesday. I look forward to seeing you.
Good morning, everyone. My name is Sherry Kona, and I am here with Tufts Health Plan. As you all are probably aware, we offer two plans, the Navigator and the Spirit. The Spirit is our limited network plan. It is limited to only Massachusetts, which does not include the islands. We have not added any hospitals, but we have also not removed any hospitals from last year, so the network will remain the same. As far as our Navigator plan, that is our full network. So it is all of Massachusetts, Rhode Island, and all of New Hampshire. Previously, it was just southern New Hampshire, so we have expanded into the entire state of New Hampshire. So we have added some hospitals to the Navigator plan, but an entire list of hospitals is in the benefit decision guide, which will be available online, as well as in the open enrollment kits. As far as the plan handbook distribution, this year we will be mailing out plan handbooks to all retirees as well as all new subscribers. Any members that are, or any subscribers that are currently enrolled right now will just be receiving a notification in the mail letting them know that the handbooks are available online. Of course, if they do want a copy, they can certainly call into our member services department and request one. That's not a problem at all. Regarding our pharmacy programs, so the most updated formulary is going to be online at tuftshealthplan.com/GIC. Members can go, right to that website. All they need is the first 3 letters of the name of the medication that they're looking for. They can search. It will bring up the tier of the medication, and if there's any restrictions, maybe a prior authorization requirement, a quantity limitation. So we certainly, suggest members going to tuftshealthplan.com/GIC to look up their medications. We also do have an alternative medication in a PDF format, so members are able to print that out and maybe go to their physician's office and, say, Dr. Smith, I see, you're prescribing me a brand name medication, but on this list there is a generic equivalent available. Is that something that may be helpful for me? That will help lower their cost as well. And how Health Plan is helping to control costs. So we're always trying to help control costs, but we do continue utilizing our medical management programs. Some of programs that have already been in place for a few years, such as the Healthy Birthday Program, our Priority Care Program. But we are implementing 2 new programs this year as well, which is the Emergency Room Department Program and our Oncology Program. So essentially with the Emergency Room Department Program, our clinical team will reach out to any member who has been in the emergency room 7 days after they've been discharged and just kind of go over what the next steps with them will be. Has the emergency room doctor given you a list of medications that you need to take? Are they telling you need to follow up with a certain specialist? So it can be, when you're going to the emergency room, it can be overwhelming. I mean, you're there because you're sick. And so when you leave the emergency room, you're given a list of, you need to take X, Y, and Z. You need to go see Dr. A, B, and C. So it can be very overwhelming for members, as well as their family members as well. So we put this program in place to kind of help them with the next steps after they've gone to the emergency room. Our oncology program, so essentially we identify members that are currently going through chemotherapy, and we do somewhat of the same thing, make sure that they're taking the medications that they're supposed to be taking, making sure that, they're seeing the specialists that they need to be seeing. Ultimately, we really don't want these people, going back into the emergency room. This is what we want to prevent them from going there. Obviously, this is a very, emotional, stressful time in these people's lives, and anything that we can do to help, ease them through this program is what we're going to do. We also have a specific member services GIC queue. So anytime a member were to call in, they're not just going to call into this big, service queue and be transferred around all different places. They're going to get a specifically trained GIC representative who will be able to go over all of their benefits, any claims questions, help them navigate the website. If they're seeing a tier 3 doctor, which is a $90 copay, they may say, can you help me find a tier 1 doctor who may have the same specialty? So that's something that some of our representatives are able to do. We also have some flyers that are available on the website, as well will be in the open enrollment kits. What is the importance of a primary care physician? How can you save money by seeing a tier 1 specialist over a tier 3 specialist? So those are some, educational materials that we want to provide to our members to help them understand how they can lower their out-of-pocket costs. I also want to mention that we will have a couple of the GIC representatives from the member services queue at our health fairs this year. So we definitely encourage all of your employees to come out, ask any of their questions. Like I said, these people handle these questions and these calls every single day. So it will be very beneficial for your employees if they do have any questions. I will be here at the end if anyone has any further questions for me. But with that said, I will pass it along to the next health plan.
Good morning. My name is Elaine Wilson. I'm with Harvard Pilgrim Healthcare. It's great to see all of you this morning. Lots of familiar faces in the audience today. So you need some updates about Harvard Pilgrim. I know that Cindy has mentioned that the Independence Plan is closed to new enrollment, and that is true for right now. Anyone who's enrolled on the plan today may stay, and of course we hope they do. If a member gets married or has a baby and they need to add a family member, a qualifying event, they can certainly do that, but nobody new can join the plan right now. For folks who are enrolled on the Independence Plan, we do have a hospital network change I want to alert you to. Berkshire Medical today is a tier 3 hospital. It's going to be tier 2. So Berkshire Medical is tier 2 now for the Independence Plan. Sturdy Memorial Hospital is as well. That's less impactful here out in Western Mass, but it's good to know about Berkshire Medical. And we, along with the Independence Plan, we offer the primary choice plan for active employees or non-Medicare retirees. We also offer the Medicare Enhanced Plan. Those changes won't affect those two plans, just the Independence Plan. We need to keep the network limited on the primary choice plan, so Berkshire's not going into it because it's moved to tier 2. So no changes to primary choice for that, but it does affect Independence, just so you know. There are some tier changes for hospitals. Some move from 1 to 2, some move from 2 to 1. So every year, I think employees should look at what hospitals are in the network, what hospitals are tier 1, tier 2, what doctors are tiers 1, tier 2, and tier 3. And that's all in all of the literature about the plan. For members on our plans, when they enroll, they receive either a notice from us about how to get their handbook. If they're an active employee or a non-Medicare person, they will get a letter telling them, welcome to the plan, we're glad to have you, and this is how you can get your handbook. And if they're a retiree, they get the actual handbook mailed right to their homes. So actives and non-Medicare get a notice on how to download the handbook, or they can call us and request a handbook, and others are mailed the handbook directly. For our pharmacy programs, we do have a couple of updates for you. Today, prescription Nexium is covered. Anybody taking it as of July 1st will need prior approval for prescription Nexium, and they still can get it. It's just going to require prior approval. Any members of yours who are taking Nexium today will be notified in writing. Letters are going out very shortly, so you may have some questions from people. You'll be aware of that. Nexium is covered with prior approval, and along with that, as of April 15th, we're covering Nexium over the counter as a generic drug, so that will be covered at the lowest copay. So new coverage for OTC or over-the-counter Nexium, non-prescription level, is covered under the plan as of April 15th, and anybody taking prescription level Nexium will need to have prior approval for that. In terms of how we are and also the formulary. That was a formulary change, and our formulary is up to date. Any day a member goes to our website and visits the formulary listing, they will see on that day exactly what tier their medication is, whether it's tier 1, tier 2, tier 3. And if they would like to print out an abbreviated formulary of commonly prescribed drugs, we have that as well. They can use that to talk with their doctors about ways they could save. If the doctor prescribes them a medication that's tier 3, they can have a handy list with them with alternatives. So that's a way that members can save a little bit on the pharmacy program. ways that we as a health plan are controlling costs. We've, for many, many years, worked with our providers in a pay-for-performance program, and we do that to reward providers for the highest quality of care, using the most effective resources possible to treat members. So providers who have great clinical outcomes and control costs, well, we have a pay-for-performance program. We have a very interesting new agreement with a manufacturer of a pharmaceutical, for instance. There's a drug called Repatha that is available to folks, and we have worked with the manufacturer on an arrangement whereby if the results are not what the clinical studies showed, if they do not perform as well, we'll have a discount on that medication that we wouldn't have had otherwise. So we do really innovative things with either drug manufacturers or medical providers, hospitals and doctors, to pay for performance and make sure that we're providing the most value to our members. Other things like the patient-centered medical home, the centered care program, patient-centered specialty care, all of that is designed to help members maximize their benefit and receive the best quality of care at the lowest possible cost. And for members themselves, ways we help members control their costs are all of our staff who work with members, our member services. When a member calls in, we are working with folks to let them know that they need to think about, gee, who is this doctor, and is he or she a tier 1 or a tier 2 provider? Do I need to see this tier 3 provider, or would this tier 1 doctor work? That will help the member have lower out-of-pocket costs, and it helps the state save as well too. We also have a program called the Cost Estimator, and if members come to our website, they can use our Now I Know tool. And if I know that I'm going to have a knee surgery, I can look at various providers in my area that I'm interested in to see how many knee surgeries they have done, what their costs are, how they compare to other providers, and that can help the member both save money in their out-of-pocket costs, save the plan money, and make sure that they're seeing a very high-quality provider too. We've got lots of member savings programs where members get discounts on health clubs, discounts on things like acupuncture or various wellness programs and eyewear. There's lots of ways for members to save. The way to get members to save the most is through education. So the more you know about the plans and the more you can tell members, and that members will actually look at their materials to read all of this, they will see the various savings programs. So I would encourage you to make sure folks are looking closely at their plan. Even if someone's not planning to make a change, it's good to know what's available so that you can maximize your benefits. Those are some of the ways we're helping to control costs. We'll be here after the presentations if you have any questions. Thanks very much.
Good morning. My name is Julia LeBrun. I'm with Fallon Health. And as you know, we offer 2 HMO products. We have our limited network plan, which is Direct Care. And the Direct Care plan mainly is a Central Mass Eastern-based plan. So if there are any of you who are in the central area and have members or employees from the central area, Direct Care could be an option for them. But when you're thinking about members using care out here in the western part of the state, our Select Care plan is our broadest HMO network plan. It goes all the way to the New York border, all the way into Boston, down onto the Cape, and it includes providers in southern New Hampshire also. The only change to our network this year is the addition of Newton Wellesley Hospital, and that is, out towards the Metro West area. So that is the one change. Both the providers and the hospital are now part of both the Direct Care network plan and the Select Care network plan. Our member handbooks, as mentioned, we are required to send them out to retirees, so the member handbook will be mailed around June 22nd to all retirees. But for active employees or new employees, they will receive the schedule of benefits, which gives an overall view of the co-payments for the services, but the handbook is made available through the member portal. So once they go in and sign up for the member portal, they will have access to the online version of the handbook. And as you know, the GIC does post it on their website also. So that's the member handbook. With regard to pharmacy, So we do have our formulary right out on the website for members to access. It's fallonhealth.org/GIC. The formulary's right there. We too have an abbreviated formulary if someone did want to print it down, but it is, again, an abbreviated formulary of the most common used drugs and the alternatives available, but the full formulary is there also for members to access and look up. If there was any change to the formulary and a member was adversely affected, such as their co-payments were going up or we were removing a drug from the formulary, we would notify the members of that change. We do have the prior auth and step therapy utilization management programs, as Glenda had mentioned, the same through our formulary. But we also have a generic preferred program under the GIC benefits for the members. And what this program is, and this is not a new program, it has been in place for years, is if there is a generic available and a member is going to pick up the brand name drug, and again, there is a generic available, the member will pay the co-payment for that drug in addition to the cost differential between the brand name and the generic. Okay, so again, that generic preferred program is in there. It entices members to try out those generic brands first. There are going to be situations where a member cannot take that generic, but they've at least tried it and they then need to go and take that brand name drug. They will be at that point able to get it with just the co-payment. So there are circumstances that are reviewed, but again, a member does need to try that generic prescription first. As to what we're doing to control costs and reduce member, I think I look at it as kind of the same, because we want to again control costs, but I think a lot of it has to go to the members' hands also. I think the CPI initiative that the GIC has done with the tiering does get to that concept. A member is making their choice as to are they using a tier 1, a tier 2, or a tier 3 physician. So I think tiering alone does help with that. We are, this year, a couple programs that we've implemented is, one is the emergency room. We're educating members on the use of the emergency room. Is the emergency room appropriate use for them? There are a lot of urgent care minute clinics popping up all over the state, and that is becoming highly utilized. A member will actually pay a lower copayment, and as you'll hear in some of these future slides, some of the plans are actually changing their urgent care copayment to be the PCP copayment. Fallon has always had that. Our urgent care copayment has always been the PCP level. If you go to the emergency room, you're going to be paying a $100 copayment. So again, what we're doing is we're educating members. We send out flyers. We also have updated our website that if a member has a sprained ankle, and they can go to an urgent care and get it taken care of there with any x-rays, then they'll be paying that PCP copayment level as opposed to paying the emergency room. That reduces overuse of the emergency room, as we know has been a condition that has been coming up for the past few years. We also offer a Smart Shopper program. So as members are going for outpatient services, MRIs, CAT scans, even inpatient surgeries such as like a knee replacement, our Smart Shopper program is an incentivized program which has a member shop to see where they can receive these services in their area. And you'll be in a couple minutes, you'll be getting a demonstration on this Smart Shopper program. This went into place last year for us. When the member goes online and shops for a program, so let's say they need an MRI, they go in, they put in their zip code, it's going to come up with a list of all the different facilities in their area that provide an MRI. It will at the same time give you that cost differential because there are more expensive providers down to the less expensive providers. What this Smart Shopper incentive program does though is it pays the member back. So if they are actually making a decision to go to a lower cost yet still high quality provider, once we receive the claim and we know that they have shopped for this program through this program, we will pay them back an incentive, and that incentive can range anywhere from $25 all the way up to $500. So it depends on the magnitude of the services and the cost of the services. So those are ways in which Fallon is helping to control costs and help the member lower their out-of-pocket costs. So we'll be taking questions in a little bit. Just so you know, out on the table there is a fact sheet for you coordinators, just to kind of give you an overview of, again, our networks and the extras that we offer. Thank you.
Thanks. Is everybody still awake? Nothing against you. I'm just saying that sometimes it's us. No, that wasn't aimed at you, Julia. We have a healthy competition as carriers, trust me. We enjoy being around each other. My name is Eric Jakes. I'm from Neighborhood Health Plan. We're based in Boston, but we do extend out here into the western part of the state, or as we like to call it, the better half of the Commonwealth. We are in Hampden County out here in Western Mass, and in Worcester County. We do not offer health insurance commercially to members in Hampshire, Berkshire, or Franklin counties, however. Nothing against those counties, please don't take it personal, but it's just we're not authorized by the Division of Insurance to offer health insurance in those areas. We're everywhere else, including the Cape and the Islands. We do enjoy coming here to these coordinator sessions, and we also really enjoy the health fairs, as Sherry mentioned a few minutes ago. So don't forget, I think you all picked up one of those lists. I'm going to be at all of them. We're all going to be at the health fairs. We're going to be joined by customer service who are specifically trained in GIC knowledge, so they can speak to people directly. And take a look at your list. They're in Worcester, Winchendon. They're here at UMass. There's going to be one in Ludlow. So all in the areas coming up in the next couple of weeks. Make sure you let your employees know about those as well. We have had some significant hospital changes. We are no longer considered a limited network plan, although our premiums are in line with the limited network plans. We've dropped the limited network label, and we're now considered a comprehensive plan, and we have hospitals that weren't available in previous years out in this part of the state that are now available. Hospitals such as Athol, Bay State and Springfield, Wing, Harrington, Marlborough Hospital, Clinton Hospital, those were all not available in the previous years to NHP members with GIC, and they are now available. So you might want to make sure you go over to nhp.org/GIC. That should be on one of the fact sheets that you picked up on the way in, and you can look at our complete network of hospitals, but it's the full list of hospitals now. With regards to the handbook distribution, again, if you go to that nhp.org/GIC, there are ways of getting the handbook online. We send out a letter to everybody who's within NHP to tell them how they can acquire a handbook. We don't send them out to every new member that joins. They're kind of thick, and a lot of people aren't really very interested in reading them. Those that are really interested can either go online and look at them page by page, do a quick search, find exactly what you're looking for, or if you need a hard copy, you can order a hard copy, and we certainly make them available. We just don't send them out as hard copies to folks, whether they're existing members or new members. Our pharmacy program has changed recently. We joined up with CVS Caremark on January 1st. We had a new formulary. We update it every quarter, so the one that you're going to see, again, I'll go back to the website again, you're going to see a formulary list there that's going to be updated as of April 1, and then it'll be updated quarterly, so any changes will be there on April 1st. We also have the abbreviated version. How abbreviated is it, Cindy? It's about 6 pages usually of the formulary. It's the most popular prescriptions that are on the formulary list that folks can print up and bring with them to a doctor's visit. So maybe they can save money on a generic when a doctor is recommending a brand name prescription. I think as far as saving money for both members and for healthcare costs in general, wellness seems to be the way to go now. As employers, you probably struggle day to day with folks, not only folks who aren't coming into work because they're not well, which would be absenteeism, but presenteeism, where people are actually coming into work and they're not doing so well and they're not really producing. Well, we're focusing on wellness from a variety of different angles. We want to make sure that people have all of the resources that they need, whether it be behavioral health, smoking cessation. We offer a terrific gym membership, $150 for the subscriber and $150 for another family member. For every calendar year, they can get reimbursement for that. So we're really trying to stress those types of things as far as wellness is concerned. And as my colleagues mentioned a few minutes ago, there are so many urgent care clinics available now for folks to go to rather than going to an emergency room. My wife and daughter went the other day with a twisted ankle to an ER because it just was the closest possible place to go. They got there at 5 o'clock and came home at almost 9:30. We're going to spend something around $250 on a copay. It's just, if you have an urgent care clinic nearby and you can use it, we highly recommend that you do. And keep in mind, when you join Neighborhood Health Plan, if you're vacationing, if you're somewhere else and you need to go to an urgent care clinic or an ER, you're going to be covered no matter where you go. We strongly recommend getting in touch with your PCP when you return so you can let them know what happened, but it's going to be covered at the same copay that it would be if you were here in Massachusetts. So that's what I have right now. I'm going to hand it off to Unicare. Thank you.
Good morning, everyone. My name is Caroline LeBlanc, and I'm here from the Unicare State Indemnity Plan. We administer 3 plans for our active employees: the Basic Plan, the Plus Plan, and the Community Choice Plan. Our Basic Plan covers members anywhere inside or outside of the United States. There's no network per se of hospitals that they need to stay within. However, we do offer out-of-state networks if a member were living outside of the state of Massachusetts. Our Plus Plan is a PPO type plan. There are really no significant hospital changes to our Plus Plan. There may be some shifting in the tiering of providers and hospitals, so I always recommend that you advise your employees to take a look at that listing when it comes out, just to make sure that nothing has shifted that they currently use. In our Community Choice Plan, we do have 3 new hospitals added to our Community Choice Plan, and that's Emerson Hospital, Lawrence Memorial Hospital, and Melrose Wakefield Hospital. So those 3 hospitals were added this year. In regards to our handbooks, we typically, for retirees, will send out a handbook, and for active members, what we do is we'll send out directions how to get the handbook online, or of course, as mentioned before, if they would like a paper handbook, we will certainly send that out to anyone that would like a paper handbook, but they're also available on our website. Our pharmacy program is actually administered by CVS Caremark. Joanna Penta is here today, and she will speak to you about the pharmacy program directly. And then some of the ways that Unicare is working with members and the plan to save cost and save member out-of-pocket costs are, 1, the urgent care centers, as Julia mentioned, we are moving those to a $20 copayment versus the $100 ER copay. So if someone uses an urgent care center for a broken bone, stitches, ear infection, you would have the PCP copay of $20. So you would save versus going to the emergency room. Obviously, if someone needs to go to the emergency room, though, we do encourage them to go as needed. Let's see here. We also offer, and I'm not sure that a lot of people are aware of it, case management for chronic diseases or illnesses. So a lot of times what happens when a member is advised that they have a serious illness, it's a shock, and a lot of questions come along with that. So we have case managers who will call out to the member and advise them not only of benefits available under their plan, but resources that are available to them in the community. We also work very closely with Beacon Health Strategies, our mental health vendor, so that if someone needs someone to talk to about this diagnosis that they just got, they can work with a case manager over at Beacon. So we try to encourage case management to people that have a chronic disease or a severe medical illness. We also do member education. So if we are notified that a member is going outside of, say, the Community Choice Network, we will call out to them and let them know to try to save them from getting a large bill, that we've been notified you're being admitted to a non-community choice hospital. If you are admitted to this hospital instead, you would have a lower copayment and lower out-of-pocket costs. If we get a claim, we usually will send a letter to the member letting them know you went outside of community choice, you still have benefits, but if you had gone to this hospital in your area for, let's say, an x-ray or an MRI or your mammogram, you would have had higher coverage and lower member costs. So we try to educate members by sending them out mailings and phone calls as well. I'm going to pass you along to Joanna Penta. I will be outside if anyone has questions after the presentation. Thank you.
Good morning, everyone. My name is Joanna Penta. I'm here from CVS Caremark. We are not a health plan, but as you can tell from my colleagues, we do contract with a number of the health plans that are here today. The benefits that are carved into the health plans like Fallon, Neighborhood Health Plan, and Tufts are administered by each of the health plans. They have medical directors on staff that determine the formulary tiers, determine clinical programs. They basically contract with us for our network as well as our claim-paying systems. So the program that I'm going to be discussing today is a CVS Caremark program where we work directly with the GIC to determine what the pharmacy benefit management program is. We are linked to all of the Unicare state indemnity plans. So everything I'll be discussing today would pertain to any members you have in the Unicare state indemnity plans. As far as our pharmacy network, it'd be pretty hard pressed to find a pharmacy that's not participating in our national network. That includes Walgreens, Rite Aid, CVS pharmacies, independent pharmacies across the country. We also have a 90-day maintenance drug program, which allows folks to obtain maintenance drugs through either mail service or through CVS Pharmacy, because we own CVS Pharmacy, at the mail copays, and GIC has afforded the mail discounts. If folks are opposed to mail, and some folks are opposed to a CVS Pharmacy, there is the availability for a member to opt out of the 90-day program and obtain their maintenance prescriptions at any pharmacy of their choice at 30-day supply. They'll have to go back every 30 days and pay the copays. As far as our formulary, I know a lot of us lived through some significant changes last July. Happy to report there haven't been any new significant changes for this July. It is a managed formulary. It is a program which includes about 200 or so drugs that are not on the formulary, but there is a medical exception prior authorization process which would allow a member to receive authorization to take those drugs. It's a 3-tier program, generics, preferred and non-preferred, and then that additional tier with medical exception process for drugs, especially if they're drugs new to market. Cindy spent a lot of time talking about high-cost specialty drugs, high cholesterol drugs. It's only for a very small subset of the population. It's about 15 grand a year, but we want to make sure that people have tried and failed traditional medications before they step up to these newer drugs. So that's what the managed formulary is there for, but there is a medical exception process, so the right folks will be obtaining the drug. No-step therapy, that was eliminated last year. There is prior authorization, utilization management, especially on specialty drugs, but I look at that as a positive. I know it's a little bit labor-intensive sometime for folks, but a lot of these, especially for their narcotics, are really limits and prior authorizations that are put in place for safety. Lastly, as far as handbooks and ID cards, please make sure you tell folks. I had one woman at the last meeting who had a member switching from Tufts that uses CVS Caremark to the Unicare plan. Again, make sure they show their ID card because the formularies are different and the claim-paying systems are under different IDs, so make sure any new members that switch between any of the plans and join Unicare shows their new ID card. Handbooks we only send out to new members, but they are available as well online, and there's a lot of resources in the great material that Cindy puts together. Availability of looking up drugs for your members, as well as encouraging people to use the website to check their claim history, reorder medications. Thanks. I think I'll turn it over to you, Cindy.
So now I'm going to open up the floor to questions for the health plans, but we're going to come around with a mic so that the question can be heard. Does anybody have questions for the health plans? Right here.
Hi, I have a question for Unicare indemnity plan. Can you give a quick definition of what's the difference between with CIC and without CIC that can be verbalized to our employees?
To be helpful. With CIC, members have a higher benefit. So if a member has the with CIC option, they have 100% coverage for most services. Without CIC, they have an 80% benefit for several services and higher copays and out-of-pocket costs. So without CIC is essentially a lower level of coverage. With CIC, they have a higher level of coverage.
One analogy is as if you were in a PPO or a POS plan and you were going out of network for all of your benefits. Mm-hmm. As Caroline said, it's an 80% coverage. We do not recommend without CIC.
Right.
Next question.
So when someone is changing plans during open enrollment and they have already gone through prior auth for a specialty medication with the first plan, how is that handled with the new plan? Does the prior auth carry through? Do they need to help?
I think with most of us, you would be required to get a new prior authorization. I had the same situation came up at the last meeting. The minute the person is enrolled in the plan, this woman was getting married, she's on a high-cost psoriasis drug, she's moving from Tufts to CVS Caremark to the Unicare plan. Once she's in the system, I would encourage that member to contact the specialty pharmacy or the customer care number. They'll help coordinate that person through the entire process. So prior authorizations will be required to be redone when you switch between the plans.
More questions?
We appear to have a drug crisis in Massachusetts. Are we limiting those kind of drugs or just pre-authing them?
Yeah, we've done a lot of work as a team with Unicare around high cost, the opioid epidemic. So we're really working together, all the health plans and Beacon on that. There are prior authorizations and quantity limits on these medications to ensure appropriate use. There's also a program that we use at CVS Caremark called Enhanced Safety and Monitoring, where we look at members that are doctor shopping and pharmacy shopping, and we are contacting those physicians, limiting their medication, tapering people down. We're also forwarding information to the medical carrier, Unicare, as well as the Beacon Health Plan.
And I think there was a law that was just passed recently in Massachusetts that stated that there would be limitations on what could be prescribed even before it gets to our level. It's the limitation from the physician themselves.
Anything else from other questions?
For Unicare, my understanding is that all doctors are covered. What if when you go, this happened to us, we go to a doctor and they said, we don't care what, and I checked the copay, and they went, and the doctor said, we charge our price. We're at the doctor's appointment. What do you do then?
We've actually had members call us from the doctor's office, whether the doctor's office calls for them or on their cell phone, and hand it to the staff. Because of the tiering, there are some doctors that are not tiered, so they don't receive a specific letter, and some of the other plans may find this too. Like a tier 1 doctor will send them a letter saying you're tier 1. That goes to the office staff. It doesn't necessarily make its way to the front desk or the person who's taking your copay. So we have had members call and say, I'm at the doctor's right now. They're telling me I owe $90, but I know it's not a $90 copay, and we've clarified it. We've also had to call because members have called us after the fact, and we've called out to them and said, this is your copayment, this is what you should pay. But sometimes it's a communication issue.
Do you want to comment on tiering?
Sure. Well, we have 18,000 physicians throughout Massachusetts that are in network. Some are tiered, some are not. Sometimes you have a physician that somebody might show up at as an NHP member, and they don't even take neighborhood health plan. That's a situation where they actually have to maybe restart and go to see someone who is in the network. We have had issues in the past because we started out as primarily a Medicaid plan, a mass health plan, 30 years ago. We have 140,000 commercial members now. Some are still stuck on this is a mass health plan, and we ask those doctors' offices to call us and say, can you confirm this member is active with you? And they certainly are. But if you ever run into a situation where someone presents an NHP card, sorry, Julia, I don't mean to be, if they walk in with an NHP card and someone says we don't accept mass health, has nothing to do with mass health. You're a commercial GIC member with neighborhood health plan.
Anything about tiering that you want to add? Okay. As far as the specialist tiering, I do recommend that before you head out to a specialist visit that you go on the plan's website to check the tier so that you can tell the front office desk, hey, Dr. Fox is tier 2 and my copay should be $60, because often they aren't familiar with what tier they should be charging. And that does happen. Other questions?
I know the majority of the health plans don't have separate pharmacy cards, I understand. I know mine doesn't. But is Unicare the only plan that has a separate pharmacy card for their members?
Well, we would have, you'll get something in the mail from us that will tell you that you have an extra care card and that you're a CVS Care member, but on the medical card itself, it will show what your pharmacy benefits are. So there isn't a separate card that you need to worry about with Neighborhood Health Plan.
Fallon is all one card.
Likewise for Harvard Pilgrim, all one card.
And it's the same for Tufts Health Plan as well, all one card.
The same for Health New England, one card.
Yeah, so the Unicare has to include Beacon for mental health and the pharmacy. There's general information, but not the BIN number, and then that's why CVS sends out a separate card. Other? Okay. Thanks. So most of the benefit changes for July 1st are for making it a better parity between the plans. So most of them are benefit enhancements. So a couple of the plans mentioned that the urgent care copay is actually going down for some of the plans. Some of the plans charged either the 3-tier specialty copay, or they charged the tier 2 specialty copay. The plans named are going down to $20 per visit at an urgent care center. And then this is great news for the Unicare Basic members. They now will be able to go more frequently for their annual preventive exam. This has been a question over the years. People have been asking for this, and now their benefit will be the same as the other plans. Also for the Unicare plans, benefit enhancements include that if you see your PCP for a mental health or substance abuse visit, it'll now be covered. Virtual colonoscopies will be covered, and coverage of early intervention services will be at 100% without copays and deductibles. And then the out-of-network, out-of-pocket maximum will increase to match what be in line with what the in-network out-of-pocket maximum is. And then because of the Affordable Care Act, there are additional services that will be covered without a copay or deductible charge, and those are named. And Unicare is introducing the new Smart Shopper program, and members can get a check of $25 to $500 depending on the procedure if they either call Smart Shopper or they use their website.
Good morning. I'm Mary Grannon. I'm Manager of Client and Member Services for Vital's Smart Shopper, cost transparency vendor that we're going to walk you through a member experience shopping for a procedure through the Smart Shopper program. Members will have access to our website 24/7. They will also have access to a call center Monday through Thursday, 8:30 to 8, and then Friday, 8:30 to 5. Members will receive in there at the health fairs a step flyer along with an incentive sheet. The step flyer will walk them through the 3 steps in shopping, first being that they need to register and log into the website. This screen right here will talk a little bit about cost transparency and cost comparison. They'll be able to view their history, any prior searches that they had. They'll also be able to view the list of services that are part of the program. Some of the services that are part of the program will not have a dollar amount associated next to them because of the fact they're strictly part of the cost transparency. The ones that are part of the Smart Shopper incentive program will have a dollar amount. Those dollar amounts can range from $25 to $500 that they can earn if they choose a cost-effective provider. So we're going to shop for shoulder surgery. The member has not scheduled to have this procedure anywhere. We encourage members to shop before they schedule so that they don't need to deal with the rescheduling of a procedure. They read the terms and conditions, they agree with it, and then it gives them their result. And that's step 3 of the 3 steps. It gives them a confirmation number that stays with that search for 13 months in the system. So it'll look for a claim. It shows us that we have 3 providers that had results, one starting with 250, 100, and then 50, I think it is. Also from here, they can click on Map View, and then it'll show them the 3 top providers. And they can click on the green circle, and they can also get directions from that point, from their home address. So the search goes from 30 miles from their home address. So that's how it searches to provide results. Results are determined based upon cost. Within the, can you just click back to list? You can see the various columns, the incentive column. If this was just a procedure for cost transparency, the incentive amount would not be there. It would just show them the cost variance, and it would show them what their cost, they can expect their cost to be based upon the plan they're in. And that's basically it. It's 3 steps, very easy. Any questions? Yes.
The question was, is this program for all 3 Unicare plans? And it is yes. It's not for the Medicare Enhanced plan, but for the 3 employee plans.
Yes. Yes. And that's a really good question, because if you tend
Mary, repeat the question because
Sure.
I didn't get the mic over fast enough.
Can you asked if you can increase the miles. So you can adjust the zip code. A lot of people tend to go to providers in the region of where they work as opposed to where they live. So you can alter the zip code.
Any other Smart Shopper questions? Mary will be outside if you have additional questions. So the question is there a sample website to show employees? They will be at the health fair with a demo, right?
We can do a demo screen at the health fair, yeah.
Okay. All right, thank you.
Thank you.
Fallon is the other plan that offers the Smart Shopper program, just so everybody knows. So 2 of our plans offer the Smart Shopper program. So other benefit changes, the Hartford was selected to continue as our life insurance vendor. As a result of the procurement, the rates will either stay the same or go down, so that's great news. And we're also enhancing the accelerated death benefit so that the benefit is now going to go up to 80%. And if somebody is confined to the home and unable to perform 2 or more activities of daily living, they will also be eligible for this benefit. There'll be new booklets and certificates that'll be mailed out to all employees. That'll probably happen the end of June, beginning of July. You will get a very small supply too. It'll be on our website. And as you know from a couple of years ago, the Hartford offers additional services to employees, such as will preparation, funeral planning services, travel assistance programs, and that's all free. And if you're even if you just have basic life insurance, you can access those programs. There's a nice wallet card on our website for people to reference. So the flexible spending account open enrollment is also switching to the fiscal year. So folks who want to enroll or re-enroll in these benefits need to do so during annual enrollment for coverage effective July 1st through June 30th of next year. On average, employees save $300 for every $1,000 contributed. This is a pre-tax program, so just like we are very strict with the qualifying status change, ASI Flex is very strict when it comes to substantiating that something is a pre-tax benefit and eligible for the HCSA program. I want to explain a little bit about this program. As you know, we have 11 employee plans, or 12 if you count with and without CIC. We do not send file feeds to ASI Flex, which is one way that we could auto-adjudicate various expenses. That would be fairly complicated to do because of the fact we offer so many plans. Most employers offer one health plan and it's pretty straightforward. You just send a single file. We would not only need to send 12 files, but we would also have to make sure that it was just people participating in ASI Flex. That's a lot of programming. There's also confidentiality issues that would need to be ensured, and frankly, we just don't have the staff to do this right now. The other issue is that we also allow state employees who are not enrolled in GIC health insurance benefits to enroll in this program. So anybody that is not a GIC health insurance person is going to pretty much have to substantiate every single expense they make using the HCSA debit card. My recommendation to those people would be to just submit a claim form. Don't bother using the debit card. Just pretty straightforward. On the, if you are a health insurance enrollee and you're enrolled in this program and you have a copay of $60, I send all of our copays to ASI Flex. So if it's a straight copay, it's not going to be an issue. They're not going to have to substantiate that. They know $60 for a specialist if I'm in Unicare Plus, yes, that matches, okay, that can go. All of the drugs, no problem. Any dental, any vision is going to need to be substantiated, and any expense that's subject to the deductible, because there's no auto adjudication involved there. So my recommendation is if you have a deductible related expense, you go ahead and pay for it up front, and then you submit the claim for reimbursement. These are where we're getting into these issues. I just want to give you some background so you understand why people are having to provide this paperwork when they do and do not have to provide the paperwork, just so you have a little bit better understanding. Poor Karen is getting inundated. She is our HR coordinator, she is our GIC coordinator, and she is getting bombarded by emails and phone calls about this program. And the bottom line is that's the way it works. That's when you're going to have to substantiate those claims. And again, my recommendation is for any dental or vision claims and for anything subject to deductible, just pay for it and then submit a claim with the EOB for reimbursement. There is the wallet card that's generated when you re-enroll online. You get a printout, it's mailed to homes, it's on our website. It's a nice reference as to what needs to be on the substantiation. So please refer to that. And ASI Flex will be talking about the program when we're completed here. Is this an ASI Flex question?
I have a question. They changed to the fiscal year. If someone's putting in $5,000 into DCAP or whatever they're putting into, how do they claim that on the cap?
Okay, so the question has to do with the deduction and the tax basis. We will answer this one question, but I ask that you hold, because this doesn't apply to municipalities. The ASI Flex program and the FSA program does not apply to municipalities. So I ask that state agencies will stay for the next presentation and you can ask additional questions at that point.
Hi, when we went to the half-year plan for the 6-month period, we were very clear that we reduced all the maximums to half of what you could do so that an employee would not go over during the calendar year. I'm happy to go further into that during our presentation. We have a particular slide that helps to address that. But when we went to the half-year plan, which we are currently in, from January 1 to June 30th, we reduced the maximum an employee could enroll in to keep them from getting into IRS difficulties.
Again, the ASI Flex and Karen will be here to provide additional information about this year's open enrollment. And ASI Flex is the one that sponsored refreshments, because as you know, we don't usually serve refreshments at these. GIC has no money. Dental vision, Davis Vision is going to continue as the vision carrier. There's some small enhancements for July 1st. If a member goes to a VisionWorks store, they'll have additional options for frames and an increased non-plan frame allowance. On the dental side, the mouth guards for teeth grinding are now going to be covered. And then we have a few new groups that are joining for July 1st. Pentucket Regional School District, Town of Winchendon are joining for health insurance, Town of Westwood and Town of Winchendon for retiree dental, and then the Essex North Shore Agricultural and Technical School District, try and fit that in magic, is enrolling for all benefits. So, as I mentioned, our forms are changing for July 1st. Most of them are posted on our website. They are not yet ADA accessible. They will be by annual enrollment. You have new forms in your packet. You'll see that Harvard Independence is listed as closed to new members. The date has changed. And the back of the form has been corrected in keeping with what we've talked about as far as Social Security numbers are required because of the Affordable Care Act. But I also want to point out that for a newborn, please, 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 please do not wait until you get a birth certificate to add a newborn to coverage. Hospital announcement letter is sufficient to add a newborn to coverage. Just send the hospital announcement letter with the form. If you don't have the Social Security number, it's okay. Just go ahead and send the form. They only have 60 days to add that newborn, or else they have to wait till annual enrollment. When you get the Social Security number, you can send it to us at that point. We're also doing these mailings to collect Social Security numbers twice a year, so we will also scoop them up as part of that process. So be sure to discard any forms you have on file. The forms will be on our website. The directions are on page 2 of the forms. Please do not fax forms to us. Do not send them by email. There's Social Security numbers on these forms, and we're trying to protect the confidentiality of people. And we have a fax machine that's in the middle of 50 people, and it's just not a good idea to fax forms. Qualifying status changes. Again, the deadline is to the GIC within 60 days. Please don't send a form without the documentation. We are now covering 430,000 people. So you can imagine, if we get a marriage certificate in the mail and no form, or a form with no marriage certificate, it doesn't do any good. It doesn't expedite it, nothing. Just wait, get the information, hound that employee, and get it into us within the 60-day deadline. The qualifying events are on our website at this address. This website address is in our benefit decision guide. It's also in the frequently asked questions section of our website. And you have that in your packet for reference. Qualifying event, the 60-day deadline, and it's prospective only for canceling coverage. So if your dependent, age 24, gets a job and you want to take them off of your health insurance coverage, need to attach the form with that documentation, but it is going to be prospective. It's not going to be retroactive, so keep that in mind. Health insurance buyout, it's very clear on the form. Yes?
Two questions regarding the forms. One with newborn. How do you want us to report the newborn Social Security? Because I had a...
All right, so the question is how to report a Social Security. You can do it a couple of ways. Most common is you've kept a copy of that form. What you can do is send another copy of that form, highlight it, and say reporting Social Security number only.
And I did that and it got sent back.
That's something you'd have to talk to operations about. Okay?
Next question regarding the form. Some of your boxes, when you fill out the form, it's like a black dot or a black X, and some are white. I had an issue with that too.
Have you tried one of the new forms?
It was the new form. It was the one from 315. And someone actually didn't get their deduction taken out. They were a new hire, and the deduction didn't come out. So, she got direct billed for it. However, some of the boxes, and I actually emailed you about this, some of the boxes show when you put the X in or you put your little dot in, it's dark, but some of them are light. And so they don't show
Okay, so if there's an issue with a particular form, these are interactive forms, and I got to tell you, I had 3 weeks to turn around a lot of materials, so there could be errors on the forms that are coming out like that where the checkbox isn't clear enough. Just send me an email as to which form, and again, we have about 20 forms, so make sure you designate which form it is, and we'll try and get it fixed. Okay? Yeah.
I know that I had the same problem, and I just made an X over it when I sent
Yeah.
it in.
What we check when we do the interactive fields is make sure there's enough spacing. And again, our data processing department had probably 3 hours to turn that around. So we wanted to make sure there's enough room for social security number, right, enough room for, you know, the name of the municipality, the name of the agency division number, the address, and all of that stuff. That's what we check. The check boxes are not as critical. As you said, you can take a pen and make an X. So, you know, we're doing the best, we're working the fastest we can, but there could be issues where you click it and it's not clear enough. You can either highlight it or you can pen an X. Any other questions?
The insurance beneficiaries, life insurance and beneficiary forms, are they changing? Do we need to request new ones?
All right, so you have a life insurance beneficiaries in your packet. Okay, so you can make photocopies of those. Both the 319 and the G500 are in your packets. Yep. Okay, a health insurance buyout. These forms come to the GIC. They do not go to you. That's made very clear on the form this year. It's also in the guide and it's on our website. So please, 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 if any employee gives you the health insurance buyout, say no, no, send it right to the GIC. If they miss the deadline, they're out of luck. Okay, leave of absence. This is for state agencies, and state agencies include offline agencies. Make sure to include the leave date, start date, end date, and the type of leave. If it is an industrial accident leave, a maternity leave, or personal illness leave, the Form 11 is also required. If somebody does not pay their premium, the only time they can be reinstated for coverage is during annual enrollment. And FMLA is 12 weeks only at the employee rate. So if it's an unpaid leave, after 12 weeks, they're at full cost. It doesn't matter what the collective bargaining is. As far as GIC rules are, it is only 12 weeks at the part cost. Questions for leave of absence? Wait until the mic gets to you. Paul, could you come up here too, because we've got to mic this.
I had two questions and you already answered one of them. And the first one was going to be about collective bargaining. I know some of them allow up to 26 weeks of leave. So I am hearing that from a health insurance coverage point of view, we're only gonna cover them for 12 weeks.
Under GIC's law, Chapter 32A,
okay.
It is only 12 weeks, the original FMLA law that came out in '93.
Okay.
32A was never changed. They changed collective bargaining and extended it 52 weeks and down to 26 weeks. But for GIC purposes, it is only 12 weeks.
Okay. The other side of that is military leave. I know you had the next slide is on military leave, but these guys, they also get 26 weeks under USERRA. So am I still hearing 12 weeks of coverage?
On the Form 1, you'll see that military exigency leave and military leave, that is totally different. Cindy's going to talk about that next. That's not FMLA.
Any other questions about leave of absence, not military leave?
On the Form 1A, it says select one, leave with pay or leave without pay. What about when it's both?
What we want you to do is if it's with pay, at some point is it going to change to leave without pay? At that point, you got to send another form for the leave without pay. All right, so when it switches from leave without pay to leave with pay or leave with pay to leave without pay, you have to let us know. What we are going to do is under our new system that's coming out by the end of the year, our new MAGIC system, we are going to track all leaves of absence from HRCMS agencies. and we are going to request the Form 11s. We are going to monitor the 12 weeks. We are going to put people on full cost premiums, because under 32A, you have to remember, the law says any employee on a leave of absence must pay 100% of their premium. That's what 32A says, that governs group insurance, with the exception of military, FMLA, workers' comp, and maternity. All other leaves are 100% regardless of what the employee or collective bargaining says. So we are going to tighten up our leave of absence process, and we're going to take those actions out of the payroll system and update our system and change the employee accordingly.
Is that's only towards an unpaid leave if they're on 12? If they're getting paid?
Unpaid leave only. If they're getting paid, you know,
getting paid
you
like
take
from a
the
sick leave
premium
bank.
out of their premium, out of their paycheck.
So if they take the 12 weeks of unpaid leave and then continue it with just a sick leave, they will not, the GIC will not pay their premium.
No, what happens is FMLA is 12 weeks. At the end of 12 weeks, on week 13, they have to be on some other type of leave. So if they're out on sick leave, which is a medical leave, they can continue as long as the agency approves the leave and they do the Form 11. That's the medical leave piece. Okay?
Next slide is military leave, which applies to everybody. So you can cancel all or part of your coverage. So let's say you're a state employee and you're going on military leave. Our life insurance plan does pay for acts of war and terrorism, so it might be in somebody's interest to keep the life insurance and then cancel their health insurance because they're getting it through TRICARE, for example. But when they return from military leave, they only have the 60 days to join up again. If they were on military leave and annual enrollment has gone by, they do have the right to change plans, but not if they are here during an annual enrollment period. Any questions on military leave?
So if they don't get the DD-14 within that time period, what happens? They need to send that in?
You have to tell me the discharge?
Yes.
It's only 60 days under the IRS rules. Yep, it has to be denied. It's only 60 days. Right. Look, the hardest part about this 125 plan is enforcing the rules. These rules are federal tax rules. These are not GIC rules. Federal government says 30 days only. We extended our own plan to 60 because we knew with the size of the Commonwealth and the number of employees, 30 days would never even work. So we went to 60 days, but these rules are not our rules. These are all 125, yeah. Now there are some people that get coverage 6 months after they leave the military. At that point, there's a letter that they get saying that your coverage is ending, and they give that date. That's a coverage ending qualifying event, which allows them to come in, which is different than when they're discharged and just come back. Some of them are covered for an additional 6 months. We'll take that letter and we'll offer the coverage.
Okay, as you know, last fall we implemented the employer group waiver plan for OME members. This is our Medicare extension members under the Unicare plan. As a result of this, there are certain federal rules that have to be followed, and that is that they have to get a whole bunch of materials before they can pick their Medicare plan. So as a result, when somebody's retiring from state or municipal service, they can no longer determine they can no longer pick their Medicare plan until they get the package from us. We will mail that 4 to 6 weeks after we get your paperwork, and it includes a customized form with the person's name and address. So if it's the insured that's 65 or over, he or she will get it. If the spouse is 65 or over, the spouse will get their own package. The at-a-glance brochure is in there, so they'll get information on all of their various health plan options. The SilverScript 12-page summary of benefits is in there. The correct rate sheet is in there, whether it's state, municipal, or RMT, return envelope, and instructions. So this is the new process, and they do get information on all of their 6 Medicare options. Our benefit decision guides, yep.
So as part of that process, when a retiring employee asks the effective date that they should enroll in Medicare Part B, they should wait until they receive that mailing from you to determine that date?
No, they can go to Medicare, they can go to Social Security and apply, and we'll tell them what we're going to need from them, because we're going to need a copy of their Medicare card.
Right, but in order to avoid the duplicate coverage of a non-Medicare plan through the GIC as well as Medicare Part B simultaneously.
They don't have it.
General rule of thumb, what we tell people is if you're retiring today, was it March 30th, for GIC purposes, you're covered till the end of April as an active employee because you pay your premiums 1 month in advance. So starting May 1st, GIC considers you a retiree. That's the general rule. So if someone's asking when they think they should sign up, that's the rule you should use. It's the end of the following month. The first of that month is when they're considered a retiree. So when they go to Social Security, that's the date they want to give them. This process here that we've done is only to elect the Medicare plan. That's it. It's only their election. It doesn't have anything to do with their effective date because that comes from Social Security. It's just that we can't sign them up ahead of time anymore with this new employer group waiver plan. So that just use that general rule. The end of the following month, they're covered as an employee, May 1st. Okay?
So the guide shipments started today, and they'll be completed by the 1st. Retirees receive their guide at home. If you have an employee who needs interpreter services at a health fair, they're deaf or hard of hearing, please have them send an email to us at the email address that's listed 2 weeks before the health fair they want to attend, and we will arrange for those services. So again, it's a 2-week notice so that we can arrange for it. Our website, almost ready for annual enrollment, will be by the time you get the email. So the rates, forms, answers to FAQs, the summary of benefits and coverage that's required by the federal government, those are all posted. The plan provider directories will all be up to date by the 1st, so those are almost ready. And again, I will be sending out an email when everything's ready. Annual enrollment starts next Wednesday. So now, Sue Cooper.
Is this working? Oh, cool. Okay. Good morning. How y'all doing? Good? Okay, we're going to talk about denial in a few minutes. Okay. So my name is Sue Cooper. I work for Beacon Health Options. How many of you have heard of my services or have been in one of my trainings? Anything you'd like to say? Oy vey. It was fabulous, she said. Isn't that what you said? What happened to my slide? Well, I have handouts with my email and my phone number out on the table. So on your way out, if you'd like, pick one up. So for about 22 years now, I provide services for the Commonwealth, municipalities, towns, cities, under the Group Insurance Commission. Any supervisors or managers in the room? You're not sure? So any supervisor or manager can call me directly for a consultation about any workplace issue you're experiencing. No one will know you called me. I don't have to give names to anyone. We can talk on the phone. I can come to your office. We can go to Starbucks. We can go to Bermuda. I don't cook. You tell me when dinner's ready, and I'll come to your house. And that's been a great service because some supervisors don't want to go to their managers. They want an outside opinion. I do not work for the state. The state is my client. And unless it's around a suicidal or homicidal thing going on, I don't have to tell anyone anything. So that's one service. I can come to your office and provide wellness seminars on any topic you want. These are free. I don't even ask for food anymore because no one has any budgets. So stress management, learning how to relax, dealing with change, learning how to meditate. These are the top requests. So again, I can come to your office and put that on for for your employees. If you need a grief group, you have a sudden loss in your office, an unexpected death, something that's bringing on grief responses, I can come in and offer grief support. Again, no charge. My services are for all employees. The consultations are for managers and supervisors. So don't give my name out to every employee in your office. Well, you seem like you need some help. Go call that Sue Cooper. So when employees need some outside support, they go to their mental health benefit or their EAP counseling benefit tied to insurance. Does that make sense? But if you're a supervisor or manager, you can call me. I don't care what your insurance is. If I come to your office and put on stress management, I don't care what the insurance is of anyone in the room. Does that make sense? I'm also a critical incident responder. So any critical incident in the state, marathon bombings, a suicide, anything that causes traumatic responses, I will go and meet with people that have been exposed to the trauma and provide what is called a debriefing. I'm a licensed clinical social worker. And like I said, I've been in this position for about 22 years now. Any questions about my role, who I am, what I do? Okay, just one at a time. It's not me, but let's say you want to talk to me because you're their manager about how to approach that employee, the referral process. Yes, you can always call me with those kinds, but the employee would go to use their mental health benefit.
Any other EAP questions?
We do lunch and learns, and we actually provide food.
I'll be there. Where do you work?
City of Springfield.
I'll be
Pizza,
there.
we only do pizza, but for managers, so we could have you come in and address a couple of these topics.
Yes, I do management trainings and supervisory trainings, teaching supervisors how to deal with challenging events and behaviors in the workplace. I'd be happy to. And you could do vegetarian pizza, right?
Well, but also, let's say HR staff wants to invite Sue in to talk about stress, or what are some of the other topics?
Yeah, I mentioned
Oh,
that.
okay, all right.
Yeah.
So it doesn't have to be the manager or supervisor, it could be a coordinator that calls Sue in to do a seminar for employees.
For the employees, yep.
Sue did one at our office for our probation department.
Oh, yeah,
They did a
I've been
wonderful
teaching
job.
probation how to meditate, and the Department of Corrections. And do I have time to put this audience through a quick meditation?
Yes, you do. One question? Oh dear. Wait.
I can't hear anything.
So my question was, if you came to an office and did one on morale, the low morale, like, because to bring up the spirits of the morale of the office, if you did that.
Yes.
Because we're managers, but like the whole office morale is down.
Right.
So to bring up the morale so that the productivity would increase.
Well,
and
that's what we
everybody
would
be-
hope.
Yeah.
It's not 100% guarantee, but what I do is I talk with whoever calls me, the manager, the director. I find out what's going on in the office, what are the issues, why is morale down, and we work on what's the best training to help that staff, maybe improve communication, maybe stress management, something invariably, of course, it could help morale and talk about how people can get along better, but give me a call, we can talk about that. And even if you don't have food, I will still come, like I said. So I want to just take a minute. I'm pretty passionate about teaching meditation, and it's becoming quite mainstream. But for a long time, people didn't really understand, and maybe some of you don't, about what meditation is and what it is not. You know, a lot of people think meditation, you got to buy, you know, like all these different weird clothes, sit in a corner for hours chanting things you don't even know friggin' what you're chanting for hours at a time. And that's not meditation. And anybody meditate in here? Oh, that's okay. How's that working for you? All right. Yeah, you look good. All right. So what people have found through studies is that meditation can lower anxiety. It can help with sleep disorders, insomnia. It can help build your immune system, boost it. It lowers blood pressure. It helps you stay present. It helps calm the mind because the mind is always going, right, 100 miles an hour. And it's very, you ever try not to think? And then when you try not to think, you really think, and then you think weird stuff. You can't not think, but you can quiet it. And meditation helps so your distractions don't take over. Whatever stresses, whatever you're thinking about from the past or the future, whatever you're worried about. You got a lot of worriers in here? How many of you are worriers? I'm talking about you worry when you don't worry. You worry about friggin' everything. It's very stressful. That's usually future-oriented. Meditation helps you stay in the present. So I'm going to put you through a quick one, just so you can get a flavor of what, and then maybe you'll continue it. You can get apps on your phone that will do guided meditations. There's a lot of stuff out there, but I just want to see what you think. But before I get started, I just want to give an analogy here of your mind. How many of you have seen The Wizard of Oz? Because I don't want to blow the ending. All right, so remember the scene where Dorothy's running home, the tornado has started, and she runs in her house, she runs up in her room, and she gets knocked out. Do you remember that, like on her bedpost? She wakes up, her house is in the air, and there's a big picture window. And all these things are flying by the picture window. Do you remember some of the things that flew by? What were some of the things that flew by? The neighbor on the bike who was really the witch. There were chickens. There was a cow. Now, was there a man in a bathtub? Was he naked? Or was that wishful thinking? I don't remember. But there was a man in a bathtub. So all these things were going by, right? And Dorothy's like, that's what our minds do. Now, I'm not saying you all have naked men going through your... Okay, never mind. But what meditation is going to help you do is not clutch everything that goes by in your head and get you distracted. So just for a minute, in a minute, I'm going to have you close your eyes or just look down. And I want you to just use your breath right now because you have it. You don't need anything else. You can use your breath to meditate. And what I want you to do is literally notice your breathing. Notice the breath coming in, going through your nostrils, filling you up. Notice, whether your belly expands. Notice the breath leaving you. Now, this is the deal. The moment you notice you're getting distracted, bring yourself back to notice your breathing. That's all I want you to do. All right? You with me? So close your eyes or look down and breathe. And again, any thoughts, fears, worries, concerns you notice, that's okay. Just bring yourself back to your breathing. Okay. How many of you had a moment of a moment, that you noticed you were getting distracted with a thought and you brought yourself back and noticed your breathing? How many had that? A lot of you just meditated. That's meditation. You can do it a couple minutes maybe in the morning, maybe a couple minutes at lunch, in your car before you go into your office, before you walk into your house, just sitting at your desk, a couple minutes. And you will notice over time, your thinking will be calmer and you won't be as distracted. So give it a try. Research it. You can get tapes. You can join a meditation group. It's phenomenal. It's a great practice. One last thing. The other stress reliever, you know how all day you're getting a lot of stuff thrown at you. Other people's angst, right? You ever sit with someone who's angry? You end up as angry as they are, maybe more. They walk away feeling pretty good and you're friggin' beside yourself. And you were fine when you sat down. So you're taking on other people's sadness and frustrations, right, and anger. So this is a Buddhist technique. What they will do at the end of a particularly stressful event or at the end of the day, they will literally wipe themselves down. They will do this. And it's a reminder not to carry other people's angst, other people's anger. It's not yours. Now, don't do this in front of anyone. Don't go up to, what's your name? Don't go up to Tim and go, have a nice weekend. It's been a pleasure. Take one of my flyers, and I hope to hear from some of you. All right?
Okay, state coordinators, offline agencies, and HRCMS and UMass, you're not off the hook yet. FSA is next. But municipalities, you're off the hook, and the health plans are out in the hallway.
My name is Karen Eddy, and I'm with the Group Insurance Commission. I am actually the program manager for the Flexible Spending Account, and with me is Gordon Sheridan with ASI Flex. You probably remember us from this past fall when we did the last open enrollment for fall. We saw many people, I believe, in Holyoke and some others in Worcester, so it's good to see you again. We won't see you again for another 12 months with the next open enrollment period, so thank you for being here and staying. So we're going to go ahead and get started. And what I would like you to do is when you came in, you should have got a nice blue packet. Go ahead and grab that because I just kind of want to walk through what's in there. There's some great resources in there for you that you're very familiar with, but also call out a few other items. Okay, so in our packet, we have our traditional FSA trifold. For coordinators, if you would like some for your agencies, please contact our account manager, Kalina, and she will go ahead and send those out to you with some quantities, but there is a sample in there for you as well. The next item I am going to ask everyone to pull out, and that is actually our participant handbook. It's got a redesign for this open enrollment period, and I would like you to go to page 6 because there's a typo. What we did was a limited print for coordinators for your packets, and it was called out to our attention that there was a typo on one of the dollar amounts. So please go to page 6. There's 2 columns. You want to go to the right column that reads annual contribution amount and administrative fee. A little bit more than halfway down in that light blue box, you want to go to the healthcare spending account, HCSA 2017. There's a dollar amount that's currently listed as 2250. We need to cross that out and change that. The maximum amount is $2,550. Again, so you're going to cross out the 2250 and replace it with 2550. 2,550 is the maximum for the healthcare spending, and the minimum remains at 250. This is available online, both on the GIC website and the ASI Flex website for employees. The electronic version will have the correct information, but I just want to make sure that I know many coordinators pull this when they get questions, so I want to make sure you're aware that we know there's a typo. It will be fixed for the electronic version. Okay? The other item, Cindy mentioned it before, we've had these before, is the wallet card. These are for you, if your agency would like more, that's another thing you can ask Kalina for, is additional wallet cards. It's a great thing to slide in right with your debit card. So when you're using it at the point of service, you can show it to whoever's giving you a receipt. I know I've done that, and that's when a lot of people have said, oh, wait a minute, I have to give you a different receipt, and then they know what to go get me. So that has been helpful. When employees re-enroll, as part of their confirmation packet that comes from ASI Flex, they receive 2 of those wallet cards, but I know people either don't realize it's there or lose it, so we do like to go ahead and send those out to the agencies. So let Kalina know if you want some trifolds or if you want some of the wallet cards sent to you. Some other items that are in here, we're going to go to the right-hand side. You can go ahead and pull out the slides so you can keep notes as we go through the presentation. Our slides for today, and then also behind there is a couple additional documents. These are all available online, but we do like to give the coordinators your own original copy. The first one is the re-enrollment instructions. Any employees that will be re-enrolling, they can be currently active in the half-year plan or were active in the calendar year 2015 plan. I know some employees did not enroll during the half-year plan. They weren't sure if they could spend down all the money in time. So if anybody who's been an active employee in the healthcare spending, either dependent care or the healthcare spending plan, they can go ahead and re-enroll online with the ASI. So if they've had ASI ever as a provider, they should re-enroll online. I can't hear you. One second, we'll just get you a mic so you can ask the question.
I have a question regarding this line we just corrected. I noticed that your limits are stating for fiscal year end. Aren't we monitoring these amounts based on what's going to go on the W-2 for a calendar year?
So yes, we are doing that. If you wait for the next slide, we'll be able to talk more about the calendar year and the deductibles, the amount that is being done pre-tax. Okay, because the next slide will help to address that. All right. So we have our onboarding instructions, and then for new hires or new employees, they should use the paper-based form. Any UMass coordinators here? Okay, UMass, you will continue to use the online process that you use for the half-year plan. We'll continue to use that. But for anyone other than UMass system, for new employees or new enrollees, you want to have them fill this out. I want to call out at the bottom, it's very clear, the forms and all forms for the FSA go to ASI. Please do not send them to the GIC. From the half-year plan, I have about 3 inches worth of forms that got sent to me. I don't process them. And moving forward, they're going to go back to the agency by mail because you mailed them to me. And if that person misses enrollment, they've missed enrollment. Do not send FSA forms to the GIC. We do not handle it. We do not enroll the people in that. It is not part of MAGIC at this time. Do not send those forms to us, okay? And we have more information on where to send them and how to send them, but do not send them to the GIC. The next one is a worksheet for employees. This is available online. This is for employees to fill out so they can guesstimate their expenses. We do encourage employees to be conservative. If they don't spend the money, they will forfeit it, okay? I'd really rather see someone run out of money than forfeit money. So please help them to be conservative. On back is a helpful list of eligible expenses and ineligible expenses that are for frequently asked questions and products. The next form has gotten a few versions of it, and it's the status change form. This would be for anybody who goes on a leave of absence, has a qualifying event. You need to fill this out. Again, this goes right to ASI Flex. It does not come to GIC. This would be to make a change in election, to start the program, or to withdraw from the program with a qualifying event after open enrollment. Okay? And then the next one is just so you have a copy. Again, this is available to employees online, both websites, GICs and ASI Flex, and that is the appeal form. The instructions on how to appeal is on the top. There's also instructions in the participant handbook. Okay, so if an employee has a request for reimbursement that goes in and is denied, they can fill out the appeal form to ASI Flex. They should contact and work with ASI Flex during that appeal process. If their appeal is denied, then that would go on to the GIC, but they do need to go through the appeal process with ASI Flex first. Okay? Great. So getting on to the question regarding pre-tax benefits and staying within the IRS limits. The IRS limits currently for the maximum for the healthcare spending is $2,550, which is what we allow employees to elect for the full year plan. And the calendar year for the DCAP is $5,000. We allow employees to do $5,000 for the FSA. If you look in the bottom right-hand corner, you'll notice that for a 26 pay period cycle, which is a biweekly pay cycle, 13 pay periods should come out of calendar year 16, and 13 pay periods should come out of calendar 17. HRCMS agencies, we've worked with the comptroller. There's a really, really good job aid posted on the Knowledge Center. Please, please use it. It really gives you detailed information about dates. It also is very helpful for when you have employees that start during the plan year or have a qualifying event. It outlines how many pay periods remain, so when you're figuring out what their deductions amount will be based on their election, it will help you walk through that. It also will help you understand the start and stop dates. It's important that we follow those, okay? That will help keep people within their tax limits. And for the half-year plan, which I mentioned earlier, we lowered, you'll notice we lowered and reduced that by half so that during calendar year 16, an employee wouldn't be able to go over the maximum for the IRS. So the IRS looks at a calendar year, tax year, and the FSA program is now moving to the state's fiscal year, like the other GIC benefits. Any questions on that?
I may be getting ahead of myself, but you did mention that, and I know that where I work, some of the people chose to skip the 6 months. The people who did, and if they want to start again, do they have to re-enroll, or do they, with a new form, and do they will they get a new card, or do they still keep the old one?
Okay, so for the healthcare spending or the DCAP, if an employee did not enroll during the half-year plan, but they were in the calendar year 15 plan, if they already have an existing account with ASI Flex, they will need to re-enroll online. Okay, in regards to the debit card, the healthcare spending debit card, there's an expiration date on there. They need to hold on to those as long as we're with ASI Flex. That is the card that will get replenished. If an employee threw out their card, we did put it in the literature during the half-year plan, they will need to pay to replace it. It's a $5 charge for a set. But that card, if they're in or out, depending on the years, that debit card, they should still use that and it would still be good. That card will be loaded for July 1. Okay, great question. Any other questions? Okay. Again, this is just another layout of the information regarding the 2017 fiscal year. Our grace period, we will continue to have the 2.5-month grace period. Right now, because we already started with the half-year plan, our grace period will be rolling to this cycle as well. So for the plan that starts July 1, the benefit plan year is July 1 through June 30th. Employees will have a 2.5-month grace period to occur, expend down their money, and that will go to September 15th of 2017. And then there's 30 days after that date to submit claims for reimbursement, which would be October 15th. Again, the maximum and minimums are there, and it just lets you know. In the fall, many of you may remember that we would have our presentations and we would talk about how we're waiting to see, because usually in the fall the IRS would say for the next calendar year if they were going to be changing anything. Luckily, now that we're going to be on a fiscal year cycle, that change from the IRS will already have taken place. Once our plan year starts, we can't change our maximums and minimums. So we will know next year for July 1 if there's any changes. There wouldn't be any changes during the plan year. Does that make sense? So let me repeat that. So even if this fall the IRS announces any changes to the caps, the plan will not change until our next enrollment period, which will be for next July 1. So in the fall, some employees may see that. Just let them know that any plan changes for the maximums will happen around open enrollment with annual enrollment in the spring. Okay? Open enrollment, it's very important that you let people know that if they miss open enrollment, they're going to have to wait until next spring to enroll unless they have a qualifying event. I know in the past for the FSA, we usually had anywhere from 10 to 12 weeks for an open enrollment. It was now going to be consistent with whatever the annual enrollment is for all the other GIC benefits. It's close to 30 days. They need to make sure that they re-enroll. Being in the half-year plan or being in the year plan before is not a qualifying event. They need to make sure they take action. I know on many of the other GIC benefits, you only take action if you're making a change. The FSA, you have to actively re-enroll each year. Otherwise, you will be dropped for that year. Employees have until May 4th to get the forms to coordinators. Coordinators have until May 11th to turn those forms into ASI Flex. ASI Flex does not need the confirmation page that the employees give you when they re-enroll online. They need the paper form sent. Please upload those through the employer portal. It's actually more secure, and it's an easy way to do that. And ASI can regularly calls through those to get those and get those into the system, or you can fax them. Please do not mail by snail mail, and do not email the forms. The forms have social security numbers on them, and email really isn't secure, so either use the secure portal or go ahead and fax them, because either way, those are actually the better and more secure with the personal health information that's on there. When you are reviewing an employee's enrollment form, please make sure that they check off what insurance they're planning in. Because what happens is employees fill it out, they say, oh, the GIC knows what I have for insurance, they don't pick an insurance plan or indicate what their insurance plan is. Their debit card transactions will not auto-adjudicate because they don't know what plan you're in. You need to actively say, I'm in XYZ plan, and they will work to match the information that the GIC provides, providing co-pays. Okay, thank you.
If they neglect to do that at the time of open enrollment, can they update that in their account at a later date?
They could call in to the customer service and say, I realized I forgot to tell you what my plan is. This is my plan. But I can tell you some employees, and when they're instructed to do that, are hesitant to. So if we could try to catch that and help them, because a lot of times they realize they didn't do it when they have problems.
Correct.
So if we can try to work to help them resolve a pretty simple problem of what your health insurance is on the onset, I think it will make the experience better for everyone.
Thank you.
Good question. Any other questions? Great. Claims processing, with the healthcare spending account, it's not a paperless process. I am in both the dependent care and in the healthcare spending. When I have expenses with my debit card that are subject to deductible, I submit my EOB, and I have to tell you, I don't pay my provider until I get my EOB, so I know what I'm really responsible for. So I just submit my EOB. And what I do to do that is I get the paper one at home so I know it's ready. I go online, I log into my health insurance, I download the PDF of my EOB, I go to open up another web page, and I go into ASI Flex's thing and I upload it. I don't have to scan it anywhere because it's already been provided to me in electronic format. Another version that I've heard of is some people, if they have a smartphone, there's actually a free app you can get that will scan into a PDF documents. So there's a variety of things that people can do rather than using work equipment to do that. And I know different agencies have different policies. So there are ways to do it in addition to faxing it. The fax still works. It's very good. I use the fax regularly when I submit my reimbursement requests for my dependent care. Please make sure that people also understand that when you're using your debit card and you do that swipe, right, that vendor is going to get paid. Your provider, your doctor, they get paid. So what happens on the other end is that you need to substantiate that. And part of that substantiation, especially when we roll over to a new plan, is when did the services happen? So, you know, we're in March, the current plan year ends June 30th, so maybe I go to the doctors in May, my EOB will take a little while to be generated, and then I get my bill in July. Well, that would be fine if I still had money left. I doubt it, but if I had money left, I could use it during my grace period. But if I don't have money left as a July 1, or if I'm a new participant, I can't use a bill that I got in July, even though the services were in May, and pay for it. I can't go back a plan unless I'm in the grace period and I have money. If you don't have money left after the plan ends during the grace period, or you weren't enrolled in the prior year, you can't use that money for older expenses. It has to be expenses that occurred during the plan year. Okay, some employees have difficulty understanding that, so if we can try to help them with that, that would be great. Then the other option is I also have a provider, a healthcare provider, that doesn't take debit cards. And so with that particular provider, I submit my EOBs and then I pay them by personal check because I get the funds and then I write my checks. I'm not actually floating the charge. The other thing is with dependent care, I use the claim form that ASI Flex has on their website. It's on the GIC website. I actually have my dependent care every week sign off that I had my child there and I put in my weekly amount. For me, it's much easier than trying to get a receipt or a statement from my provider to submit. Just having them sign their name and indicating what type of service it was tends to be a cleaner and faster process. So I would encourage that for anyone who's using the dependent care as well. Participants have always been instructed to keep their receipts. It's really important. The credit card receipts are nice, but they really don't substantiate in regards to the IRS expectations. So they need to be aware that the credit card receipt is nice, but you really need the detailed receipt. And then funds don't carry over indefinitely. There's other plans that do that. That's not the design of this plan. We do have the 2.5 month grace period to spend down so that hopefully people don't forfeit funds. Okay? Changes to elections. People will be happy. Anyone who's ever had anyone with a qualifying status change in the past, and then even in our current plan year, employees have 30 days. As of July 1, that will change. Employee will have 60 days, which is in sync with the other GIC benefits. That way there's not a disconnect between the two. So as of July 1, GIC benefits for a qualifying status change, you will have 60 days to complete the paperwork. Okay? I think that's good. And then the form needs to be completed. Again, please send it through Secure Portal just to make it more secure because there's a lot of personal information on those forms as well. Qualifying status changes. DCAP, in addition to the ones that were discussed earlier regarding qualifying status changes, those are relevant to the healthcare spending account. But on the dependent care, there's additional qualifying status change. So if you have a child who's school age and they go to school and then they go to summer camp, when they transition from that school to summer camp or back into school, each time that happens, that is a status change. Okay? Or say your child's birthday is in September, but you know you're going to have to do summer, so you can enroll in the DCAP. When that child turns 13, that's a qualifying status change to stop deductions. Okay? The other item is if you go from full day to part day, if the provider changes, and if the cost goes up. So maybe there's an increase. Whatever that increase is, that would be a qualifying status change to modify. I don't think anyone's ever told me they got a decrease from their provider, but I'd be happy for them if they did. That would also qualify. And also if they move and therefore they have to change what they're doing for provider for dependent care, that also qualifies. So there's a lot more things during the plan year, unlike the healthcare side, that would allow. These qualifying changes are in addition to the ones that you can have for the healthcare side. Okay, so it's just a more extensive list for the dependent care. IRS grace period, and with this slide, I'm going to hand it over to Gordon so he can go ahead and walk us through the next couple of slides.
Grace period is a time the IRS allows you to spend the old year money in the new year. It's really convenient. It's under IRS Section 125. Funds can't be carried over the next year, but you can spend the money. It's a 2.5 month period. September 15th is the one for the current half-year plan, and going forward, September 15th will be the new grace period end, and that is a bright line. It's not sometime in September, it's September 15th by the IRS. You have until October 15th to get the paperwork in. That's the claims deadline. How grace period claims are processed. Let me give you a personal example on this. My wife had a procedure in February, and as of when I left home last weekend, it had not been turned into the insurance yet. I've still got some money, and I have until March 31st to file claims. So what I did, I took just the gross bill from the provider without any insurance adjustments or anything like that and turned that in to use up all my OER money, because if we go to the doctor today and swipe the card for copays, that would have gone back into the OER money. I don't want that, because I've got a bill that will take care of the OER money. So it's whatever transaction hits first, not when the date of service was, but when the transaction was requested. Any questions on that? If your card has been deactivated or frozen, you need to log into your account to see what documentation we need, or contact us, ASI Flex. Our website is asiflex.com. We have a /GIC. It's where you need to be. That has all the GIC information on there. As Karen mentioned, an EOB is a perfect example of the documentation we need. It's got all the information on there: who had the service, who provided the service, what the participant responsibility was, when it was, those sort of things. Do not, Karen wants me to emphasize, do not call the GIC. They do not have access to participant accounts. That's personal health information on our system only.
Recently, it was brought to our attention that some employees are trying to log into the ASI Flex website, and they're having difficulties when they're using Internet Explorer. More than likely, it's because they have an older version of Internet Explorer. If you're using a different web browser or an updated version of Internet Explorer, that problem goes away. And I also know that as a state entity, many of us have older Internet Explorers so that we can use other state systems. So if they're experiencing that problem in the office, it's more than likely the Internet Explorer. They should try one of the other web browsers to access the accounts or to get the mobile app.
Thank you, Karen. Also, you can submit claims by the mobile application, which I like. Karen mentioned she liked to fax hers. I like to send mine by my mobile phone. Log in, take a picture of it, submit, and you're finished. The ASI Flex card, the debit card, when it's swiped, it actually pays the account for you, pays the bill for you. You submit claims by toll-free fax or U.S. mail. The mail is slower these days, and they will admit that. So we think that's the last choice. Fax, upload, mobile app, or preferred ways. Claim documentation. This is very important. This is probably the most frequent question we get. If you're covered by insurance, medical, dental, or vision, the explanation of benefits is perfect. Or failing that, an itemized statement. In the case I just cited, my wife, we had the provider bill, had her name, date of service, what the service was, amount of money, and that worked. If not covered by insurance, we have to have the 5 things, 5 items on there. Who provided the service, who received the service, what the service was, when it was, which is during the plan year or grace period, and how much is the patient responsibility. Over-the-counter drugs and medicines. Congress sort of threw us a curveball a couple of years ago. You need a doctor's prescription to get over-the-counter medicines, aspirin, Tylenol, so on like that, and the receipt from the merchant. For medical supplies, items which we'll see in a minute, Band-Aids, blood pressure cuffs, contact lens solutions, those kind of things, just need the itemized merchant receipt. And most of the larger drugstores have something that says at the bottom FSA eligible on the transaction slip. Prescriptions are good with the pharmacy receipt. Some people wait until late in the year, get a printout from the pharmacy of all the prescriptions they've had to get a check to go Christmas shopping. However you want to do it, it's fine with us. But the pharmacy receipts are good in and of themselves. We have some assistance for your elections on our website, asiflex.com/GIC is a tax saving estimator, and the health expense planning worksheet, which is in your packet, is also on the GIC's website, GIC/FSA. New hire benefit effective dates. The health care is a 60-day waiting period. Healthcare spending account, 60-day waiting period. Dependent care, no waiting period. And here's an example on the next page. Let's say somebody's hired today, April 30th. Therefore, 1st of June would be when their coverage would begin. And you deduct a month in advance for their premiums, but the coverage would begin on, in this case, 1st of June. Next week, after April the 2nd, maybe April 5th, 1st of July would be their benefit effective date. Again, the dependent care is effective immediately. Health care has a waiting period. The employer portal, every entity has got their own credentials, unique to them. We post enrollments and payroll discrepancy reports on there. The coordinators can upload forms to there, status change forms, enrollment forms. Do not mail or email them. Again, these forms have Social Security numbers on there. Email is not considered secure. Enrollment forms and change forms can be uploaded through the portal. Offline agencies, most of you, probably all of you, already contacted us to set up the program and payroll file. If you have not gotten that done, just contact us and we'll get set up, give you credentials, and get your pay dates. 5 days before each pay date, we expect you to send us the FSA contribution and change report. If it's not sent, we put everybody in your agency on hold because we don't know who's come or gone or what any changes have been made. Once we get that, we will send you back a discrepancy report within 2 business days listing each discrepancy. And these have to be worked, as the saying goes, looked at, reconciled, tell us why there was a discrepancy. Any participant not, question? They want it to be sure to go on the video, I think.
Here you go, the video. Here you go.
On the, every week we're getting an email saying there's a discrepancy, and we go in, there's no discrepancy. Is there a reason why we're getting these emails?
You would get an email every week. We don't not send one if there's no discrepancy. You get one every week.
There's no discrepancy. When we go into the file, there is no discrepancy.
I will ask why that is. It should say none, but we're going to send a report every week.
Mm-hmm.
If there are none, it should say none. It should not say hunt and seek, and see if you can find something.
Yeah.
Thank you. I will take that back.
If you do get something and you're not sure what it is, you should reach out as the coordinator. You should reach out to our program manager, Kalina.
Yes. If a participant is not on the payroll, we will immediately put their account and debit card on hold until the issue is resolved. We notify you by email that so-and-so is on hold. When the issue has been resolved, the debit card is turned back on and coverage is for the whole period. There's no gap in coverage. We go back to the date it's turned off, turn it on, process any transactions that have happened in between. Refunds for payroll errors. I think Karen may want to say something about that.
Hello. So last year was unique because we had 27 pay periods for payrolls that were run bi-weekly. In HRCMS, we had over 700 payroll errors that last 27 pay period that needed to be corrected. When early retirement happened back in June, we've had over 200 errors. Deductions were taken that should have been stopped. Those are just large scale errors that I'm getting. I can tell you when I first started running the FSA program 3 years ago, in a quarter, so I would maybe get 30. I got 12 last week alone. The number of errors is just astronomical. And it's things such as, oh, we started the deduction too early, we started it too late, we never stopped the employee's deduction because they never re-enrolled, things like that. One that was really interesting to me is I had a request for a refund for a deduction that happened on someone who retired 10 months ago. And so things need to be more timely, and things need to be, we need to be mindful of what we're doing. When someone's keying in, and I know there's a lot of keying in with the benefits, you need to make sure that if that employee is in healthcare spending, that you're only taking healthcare spending and not DCAP and so forth, because those are all corrections that need to happen. So please, let's be mindful of that. If you're an HRCMS agency, again, that job aid is really helpful. Please use that. It's a good resource for you. The other thing is moving forward as of July 1, for payroll deduction errors, refunds need to be made with post-tax money. Currently, that's what happens because it's a pre-tax program. And so what happens, especially if we go over into a new calendar year, we're now talking about tax years, so a W-2 needs to be corrected. There's a whole bunch of compounded problems when deductions don't start or stop correctly, or the wrong deductions are taken. So moving forward, as of July 1 for the July 1 plan, any payroll deductions that happen after 60 days, the GIC will not authorize a refund. It will be on the agency to take care of the refund for that employee. So the example I said 10 months later, I had a coordinator come to me because a deduction happened, the GIC will not enforce our team or the comptroller to process that request. The agency needs to work with that. Because what happens is when there's a problem with payroll, discrepancy report goes out. 60 days, that's 4 or 5 discrepancy reports. The employee, it's also in the employee handbook, people will know. After 60 days, it will be on the agency to handle that refund. Prior to 60 days, you'll still do the typical process of requesting a refund, and we will work with you to do that. But beyond 60 days, it will be the agency's responsibility. Okay, so you really want to be aware of your payroll deductions and what's happening with them. Also, payroll error refunds, there is a change. Currently with UMass, what happens is there's a manual correction for that within the system. Moving forward as of July 1, we'll be working with the comptroller for HRCMS agencies, and they will be manually making those corrections. So anyone who's ever gotten a refund currently, you get a paper check, then you have to figure out how you're going to refund that employee. So what happens moving forward is if it's in the same calendar year, so if there's an error in July that someone didn't re-enroll in the plan and deductions happened, what will happen in HRCMS is the comptrollers will go in and fix that error, okay, and the credit will happen. However, if the error happens and then it's now January 2017, you will get a paper check because it's across calendar years, across tax years. Okay, does that make sense? So we are trying to help streamline this and make it a little smoother so that agencies aren't getting a check and wondering what do we do with a live check made out to the Commonwealth. But the ideal here and the goal is not to have errors to begin with so that we don't need to do refunds. Okay? I'm happy to answer any questions on that either now or offline. Offline agencies, we will continue to, we don't get a lot of requests for corrections with offline agencies. We would continue to issue checks for those types of situations. Okay?
Let me recap some important dates. Open enrollment ends May 4th. Collect all forms by then. May 11th, send to us, ASI Flex, all paper forms. If you think about it, if somebody enrolls online, we have their data. They print a confirmation form out and give it to you, and you can set up the payroll deduction. With the paper form, they turn it into you, so you set up the paper, their payroll deduction, and then you send it to us so we can see what we expect to receive. Both sides of the process are handled in different ways, whether it's enrollment or paper form. By June 20th, deductions must be entered in the payroll system for the July 1, 2016 payroll, including the healthcare spending account fee. review your payroll calendar to ensure deductions are entered correctly. HRCMS and UMass enter both the DCAP and/or healthcare spending and the HCSA fee deductions in the payroll. There's only one fee even if you have both accounts. The fee deductions will be taken the first pay period of each month. Prevent payroll errors. Carefully review the enrollment forms, payroll deductions, codes, beginning and end dates entered in the payroll system. Final reconciliation. May 26th, we will post a final enrollment roster in the Secure Employer portal to each coordinator. You'll also receive a report of employees who didn't re-enroll for FY 2017 so that you can stop their deductions. You've got to stop their deductions before they get into the new plan year July 1. If there's an employee on the enrollment report that you don't have a form or the online enrollment confirmation for, contact that employee to get one. They should have the paperwork. If you have an enrollment form of someone that's not on the enrollment form, contact us. We need to find out who that is. Here are our contacts. Account manager is Kalina. Please do not give her name out to participants. She has a great deal of work to do for the coordinators, and others can help with participants. And our contact information is on the right hand side. Customer service is 8 to 8, Monday to Friday, and midday on Saturday, 10 to 2. We have some appendices here. I'm going to go through very quickly. It's sort of a recap of Flex 101. What is a flexible spending account? It's a pre-tax program to cover medical and dependent care expenses. Excuse me, wrong way. You have to re-enroll each plan year. Pre-tax elections come out of the participant's paycheck, including a pre-tax administration fee. Federal and state income taxes are taxed on a lower salary. The healthcare spending account is for out-of-pocket medical expenses. The annual election is available on July 1st. That's very good if everybody in the family needs eyeglasses or somebody needs dental work. You can spend the whole thing in early July. Participants may be eligible for COBRA depending on the status of their account when they leave. These are some eligible expenses: doctors, dental, vision, treatment. Over-the-counter supplies I mentioned are eligible. Insulin test strips, hearing aids, first aid kits. Ineligible is cosmetic surgeries unless resulting from disease or illness, birth defect, accident, somebody goes through a windshield, somebody gets burned, reconstruction following surgery. Ineligible is hair transplants, insurance premiums, vitamins for general well-being, things like that. DCAP eligible expenses: care for dependent children up to the 13th birthday. A child turning 13 is a change of status. A person of any age who can be declaimed as a dependent. Child care at a daycare center, nursery, or at a private sitter, before and after school care. Ineligible is education or tuition or overnight camps. You may get that question this summer. The child has to be in your house 8 hours a day. Overnight camps are not eligible. The Flex card, as Karen mentioned, is not paperless. It's good for 5 years. We reload it each year. It'll be ready to go July the 1st. If we need documentation, and this you see this from our notices, initial notice is sent about 5 days after the transaction. We send a reminder 60 days later, a final notice 30 days after that, and a deactivation notice 30 days after the final notice that the card's being turned off. So that's 4 notices. That should be plenty of notice for someone to realize that there's a problem, that they need to get some documentation to us. It was mentioned earlier about we can do the co-pays. That's why it's very important, as Cindy mentioned, as Karen mentioned, on the enrollment form, indicate what medical plan you're in. That way we know what co-pays you're going to pay. If we don't have that, you may go in for what you think is a regular $20 co-pay, but if we don't know what plan you're in, we don't know what that is. recurring expenses for the same amount, same provider. You go back to the chiropractor every month, your child goes to the orthodontist every month. Once we have substantiation for the first one, we can say the others are recurring, same expense, same provider. But basically, other expenses at hospitals, dental, vision, we're going to need some documentation on because we can't ascertain what happened, who had the service, and so on. Qualifying changes in status, we talked about that before. Marriage, dependents. Any questions? Yes, ma'am. Here.
Oh, thank you. I actually have 3 questions. Number one, I was under the impression that elder care expenses were covered under DCAP. Is that wrong?
The question is elder care expenses covered in a DCAP? If the person is your tax dependent and lives in your house, it is eligible.
Okay.
In other words, that eliminates nursing homes. If you have a relative in a nursing home, that doesn't count. But if your parent is your dependent and lives in your house with you, and you drop them off at the elder care center, that's eligible. That's daycare.
That's DCAP.
To enable you to work.
Okay. The second question is, health, HICSA, there is a 60-day waiting period. There is no such thing for DCAP for a new hire. I get that. How about if I have an employee who says, without a qualifying event, no new baby or anything, all of a sudden decides to take advantage of DCAP to pay for childcare for a 6-year-old that they had? Is that allowed?
Yes.
Changes for DCAP would be effective the next pay period if when it happens. In regards to the healthcare spending, it would still be that waiting period.
Okay, yeah.
Just like on the health insurance. But
So
on the DCAP, it's right away.
So any employee can come into DCAP
If
anytime?
they have a qualifying status change after open enrollment, they can, yes.
Well, that was my question. So
They
it
have to have a
does-
qualifying, after open enrollment, the only way into either plan is to have a qualifying status change.
Oh, so DCAP also requires that. Okay.
Yeah.
And then the last question, maybe it's a stupid question. When should the first deduction be for this upcoming plan year? Is it? I always have trouble with that one.
We should talk offline because not everyone's in the same payroll system, but that's a great question. HRCMS agencies, again, use that deductions. On your second page, there's, for 26 pay periods, there's some general guidelines and recommendations for starting and stopping. But if you are in a different agency, we'll be happy to walk through that with you.
Yes.
Any other questions?
I know there's always an issue with dental coverage, and often those are things that require the documentation. At one of our previous meetings, you mentioned that there was a form that if you're paying your orthodontist the same amount every month, that there's a form that you could submit so that you're not getting the documentation requests every time. Where do we find that form?
I believe it's actually, when you have a contract with your orthodontist, you're going to send that in to show that you're in a payment plan. And that is one of the few exclusions, is orthodontic work. If you're in a contract with the actual doctor, not a finance company, you can have that contract and you would forward that contract to indicate that there's a payment plan, and those would go across plan years.
Okay, and it has to be a payment plan with a doctor.
It has to be the doctor. It can't be one of the fiscal ones or the interest-free credit cards they offer you. It has to be with the actual provider.
Okay, a second question is, you talked about if somebody has an ineligible expense, and so you've put it on your card, it's rejected.
Okay, so what happens if someone does an ineligible expense and then they realize it was ineligible? They have a couple of options with that. One is they could pay for something else, not using the debit card, that will go against that. They could write a check to pay that back to the plan to make that account whole. Because basically that ineligible section will hold up those funds and will actually hold up their account if the time goes too long. So what they need to do is rectify the account because the IRS will say we can't do anything until that's cleared. So they can either write a personal check for that dollar amount, or they can say, in the meantime, I have these other medical expenses that I'm going to use other funds for, non-FSA money, and submit those receipts to offset it.
Right, so if you've submitted something, you send in the documentation, and at some point somebody says that's not eligible, the documentation isn't sufficient, you shouldn't have paid,
Correct.
shouldn't
If
have
I,
used your card.
if I go get my teeth bleached,
Yeah.
right, it's at a dentist, he's, you know, so the FSA card would have worked, but my teeth bleaching is not considered necessary, and, well, depends on the person, right? So teeth bleaching, whitening isn't necessary. So I'm gonna have to refund my account. I have two ways to do it. I can write a check for that amount and clear it, or I can say I have these other eligible expenses that I paid through some other way, submit that to offset it.
Okay, thank you.
And I have another question over here. Oh, right there, too. Okay.
I have somebody who's currently enrolled and said that she's not going to re-enroll for July. Does she have to do the termination form, or does she just not re-enroll?
No, she just does not re-enroll. Good question. This is an open enrollment item, so employees have to actively re-enroll to stay in the plan. So if they don't actively re-enroll, they will be dropped off.
And the deductions will stop, or do I need to contact HRCMS and have that deduction stop?
So what will happen is ASI Flex will send out in May, I believe it's on the 26th or the 25th, 26th? On May 26th, they'll send out in the employer portal 2 reports. One says, these are the employees who signed up for July 1. Make sure you start your deductions. The second one will be these are employees who are currently in the plan who did not re-sign up for July 1. Make sure you stop their deductions.
Okay, and then goes to a question about somebody saying they're getting an email every week about discrepancies. I don't get one every week. Am I supposed to be getting one every week?
Not necessarily.
Okay.
The email is supposed to be going out when they upload something into your employee portal they want you to look at.
Okay.
So it's supposed to notify you that you need to go in, log into the secure portal to see the information.
Okay.
If there's nothing there for you to see, you shouldn't get an email.
Okay.
That being said, I know some people have retired, and what people have done is said, oh, well, here's my user ID, and here's my password. And so people are using someone else's user ID and password as the agency one. And so an email is probably being generated to someone who's no longer at the agency. So that's why it's important, even if you have 5 people who work on the FSA, if they're appropriate to have access, work with our account manager to make sure everyone has their own secure login and password to the employer portal. And I know there was another question.
Just a quick question about COBRA. When an employee resigns as a benefit coordinator, are we responsible for giving them any type of COBRA information?
No, not for the FSA. For the other GIC benefits, there is information you should give them. For the FSA, what happens is when they retire, and really COBRA is only eligible for the healthcare spending, because the DCAP, as long as you're working and have eligible expenses, you can submit for reimbursement. So the DCAP doesn't need COBRA. On the healthcare side, the only people who would know if they're eligible for COBRA is the vendor. Because what happens is, if I'm mid-year and I'll try to do even numbers. So if I enroll for $2,000 and I retire after 6 months, or I leave state service after 6 months, I put in $1,000. So at that point, they're gonna look and say, you've contributed $1,000, how much have you spent? If I spent less than $1,000, then I would be eligible for COBRA, and ASI Flex will send them their information as to how to enroll. If I spent $2,000, or if I spent $1,500, or if I spent $1,001, I am not eligible for COBRA, and I would not get notified. So if you spent more than you've contributed at the date of your separation from service, you would not be eligible. If you spent less, you could be eligible.
Thank you.
Any other questions? Great, and I do have one more question for everyone else. Who here is an agency that is using the new HRD's new services, Mass Careers, for posting, onboarding? Okay, so for July, the FSA will be part of the onboarding package online for new hires. We're working with HRD to make that happen, so that will be moving forward. Okay, if you have no idea what I'm talking about, don't worry, it's okay. You'll have it someday too, probably. Thank you all for coming, and have a great day.